Quebec on the National Youth Council and established awareness committees both at high school and CEGEP, enlisting her friends to educate teachers and classmates alike. Jackie showed resilience, never wanted to be treated differently than others, and most of the time she was thriving and living life to the fullest, pursuing her hobbies and her interests until the age of 21.
At which point, unfortunately, Jackie received a diagnosis of cancer, which was a big blow. And nonetheless, she, for 4 years, continued her positive attitude, clung to life, was incredibly resilient, and showed the Jackie grace as always, until she succumbed and passed away at 25. During her last few years, spent mostly in hospital, Jackie was talking and dreaming about things that she'd like to do and change for patients like herself and others who are suffering with different life events. And so after her passing, in order to continue her dream and her work, her legacy, we started her foundation, as you can see here. And part of that is the endowment fund that was created within Crohn's Colitis Canada for education specifically about the disease in many forms, one of which is supporting the Symposium, which is an annual symposium here in Montreal for education about IBD. And we'd like to tell you so much more about Jackie and her life and her activities. Her passions. We can't do this. We don't want to take away from Dr. Friedman's time anymore. So please, we ask you to, at your convenience, log on to jackie.org, learn about her, and any comments are welcome, of course, there as well as through Crohn's Colitis. We'd just like to take another minute to add Mariana's thanks to all the presenters today who so generously gave up their Sunday to be here with us. We want to thank Mariana and Cindy, the Montreal office, who included us in this process of preparing for today and were so generous in putting in the work for this. Thank you. We also want to give a shout out to some people who are constantly promoting IBD Month, promoted this event and are always in Jackie's corner, and that is Mike Cohn of the Suburban, Corey and Matt of Life Unrehearsed on CJ 8800, and Jose Persico. Heartfelt thanks to you. And then to all of you who joined us here today, we're very excited to have you here. We hope that you'll learn and enjoy the day.
Enjoy. Have a great day.
Thank you very much, Larry and Rena. We really appreciate your support with making this event happen. It is really important. And now I'm going to present Dr. Gad Friedman, who is a gastroenterologist at the Jewish General Hospital and an associate professor at McGill University. And he actually spearheaded the creation of an accredited nurse education program in gastroenterology. So he did this actually 8 years ago, and it's a first of its kind in Quebec. So Dr. Friedman teaches fellows, residents, students, and nurses, but most of all, he loves teaching his patients. And today you're gonna hear from him. And to facilitate patient education, he also created a website, ourdigestivehealth.com, which he'll present shortly. That helps patients better understand their digestive system and some of the common symptoms they face. Thank you very much. Now, Dr. Friedman, the floor is yours.
Good morning. I'm just going to share my screen, if I'm able to. Okay. So again, good morning, and I'm very thankful for Crohn's Colitis Canada and especially the Jaclyn Fisher Foundation for inviting me to talk to you about a subject where I really am passionate about, and I think it's kind of your first step into better health, and that's preparing for your appointment with your gastroenterologist and really This would help you to prepare for an appointment with any physician that you're going to see. So I wonder how many of you have, sat in your doctor's office, the visit's finished, your doctor's probably left to see the next patient, and you're just about to get dressed, and you're thinking to yourself, I didn't get to say everything I wanted to say. Or perhaps you sat there and said to yourself, I didn't really understand what my doctor was talking about. I know he talked about treatments and medication and so forth, but I didn't really understand it. And I think I was too embarrassed to stop them and ask them more questions. Or perhaps you even felt even worse, that maybe the doctor wasn't really listening to you, that you really weren't communicating well with your doctor. Would it surprise any of you who have maybe experienced some of these issues that if I asked your doctor what they felt about your visit, they probably would have said that everything went well, that my patient understood everything, I got to talk about what needed to be talked about. So somehow there is a disconnect between what your doctor is thinking and what you're thinking. And the question is, why is that happening? Why is there a communication issue between the two of you? And it's quite possible that both of you are talking a different language, that somehow what you're trying to communicate to your doctor is not what your doctor's hearing, and vice versa. And that creates a problem, because if you can't communicate well with your doctor, you're not going to get all the information that you want across. You're not going to get all your concerns across to your doctor. So somehow we have to find a way that you're talking better with each other rather than just to each other. Because in my opinion, a good patient-doctor relationship is so important for your health. If you can't talk about your concerns with your doctor, that means you can't really get across what's bothering you, and then your doctor has no way of knowing how to help you better. And so this lecture, this talk today, is about finding a way of improving that doctor-patient relationship and starting you off at the first step of better health. Now, the first step really is actually being prepared. And we're going to go through how to be prepared. So in terms of how to discuss what your symptoms are and with the questions that you should be prepared to ask your doctor. But being prepared is crucial in terms of what you're doing when you're being prepared for your visit with your doctor. Is you're telling your doctor that you want to be a strong advocate in your health. You're showing your doctor that you are fully invested in being healthy. And when you're fully invested, it energizes your doctor. I mean, that's how I feel. It energizes me to be just as fully invested in your healthcare as you are. And so in a sense, it's the first impression that you're giving to your doctor when you're first, in that visit, that you are going to do what it takes to get better. So how do we prepare? The first step in being prepared is having a dossier, a file, or a folder about who you are. This folder contains a variety of information that we're going to go through, but the idea of this folder is that you have it accessible at all times. But most importantly, when you're seeing your doctor for the first time, or let's say when you're seeing a new gastroenterologist for a second opinion or in the emergency room, because there's a lot of information that needs to be transmitted in that first visit. And if you have access to that information on hand, you make the process of transmitting that information so much faster. Now, as we go through the information that we're going to look at, we're going to think to yourself and say, well, the doctor should have access to all this information. Why do I need to give it to him? It's his job or her job to have this information. And that's true to a certain degree. And we do have access to a lot of information. But to search and rummage through your hospital files and all the reports to find all this information takes precious time from the time that you have to talk with your doctor. So the more that information is at hand, you simply make the job easier and you make the process smoother. So what kind of information is necessary? Well, the first thing is having your past and present medical issues. And here it's important not to rely on your memory. Too many people forget the details of their past history. So what you want to be able to have is, let's say if you had a surgery, when did you have your surgery? Where did you have your surgery? You have the surgical report. That's helpful for us, a gastroenterologist, because that information may impact on the decisions I make on your treatment plan. And same thing with your present medical issues. If you're, let's say, followed by a rheumatologist for arthritis, well, it helps me to know who's your rheumatologist and where you're being followed in case I need to coordinate care with them. The list of medications. Again, this is not just a list of the names, but why you're taking them. I think it's important for every patient to know why they're taking their medications, but sometimes there are medications that have, different, variety of usages. And so it's very helpful for me to know why you're taking the medication and so I know how it will interact with other treatments that we may be offering you. Family history is really important too. And again, something that people should not rely on their memory for. Unfortunately, a lot of families don't talk about their history, so people don't often know the exact details, but there's certain things that are really important, such as if you have a family history of colon cancer and who in your family has colon cancer, what age did they have colon cancer, or if, let's say, someone had lymphoma. Both of these factors will change how I view you and change what type of medications I may choose or how I follow you in the future. And lastly, a copy of your test results. Again, this is something that most people assume that the doctor has access to. Now, if it was done in my hospital, let's say if it was done at the Jewish General Hospital, I would have easy access to it. It's not a problem. But often people may have test results that are done privately or in a different institution, and they weren't sent to me. So the faster you have that access to that information, the better.
Sorry to disturb you, Dr. Friedman. Whoever's just logged in or came in, could you please mute yourself? We just don't want to disturb conversation. So if you've just logged in, please mute yourself. Thanks so much. Sorry.
No problem at all. So again, if you have all these things in your folder, it makes it a lot easier for your gastroenterologist to review that information quickly and simply, and then spend more time talking to you about what's bothering you right now, and then spending more time being able to talk about your diagnosis and the treatment plan, rather than spending all the time simply gathering information that you could have had, it could have been easily accessible right from the beginning. Now, when we're talking about patients with inflammatory bowel disease, in that dossier, it's also good to have a few other specific details. It's important to have details about the extent and severity of your disease. It's troubling sometimes for me when patients, let's say with Crohn's disease, come in and they don't know where they have inflammation, what part of their bodies have inflammation, or the severity of that. Now, it's possible that they were never told and that information wasn't given to them. But that's troubling on its own. And so it's important for you as a patient to know that, because that'll help, especially if I'm seeing you in the emergency room, to really get an idea, are the symptoms that you're talking about, could they really be related to your disease or to something else? Know if you have extraintestinal manifestations. Now, extraintestinal manifestations means diseases or problems that are related to your inflammatory bowel disease, but are not part of the intestine, such as eye problems, joint problems, skin problems. Now, of course, your doctor should be asking you if you have these issues, but again, it's important for you to know that you have them and that they are related to your disease, because it's helpful information to speed up the process and to make things more concise and smooth. And lastly, know what treatments you've had in the past. This is really hard sometimes as a gastroenterologist, especially as a second opinion or an emergency room, to know or have access to what you tried in the past. And even if we did have access to it, we may not know why they were stopped. So in a sense, it's worthwhile for you to know, did your medication got stopped because they simply stopped working? Did they ever work? Or maybe you had a side effect to the medications that stopped you from using the treatment. So again, all these things are worthwhile to have in your dossier of who you are. Which brings us to the more present thing. So that dossier was about your past. But when you're coming into your this visit with your gastroenterologist, it's really important to have notes which are going to contain notes about what's bothering you now and the important questions that you need to ask. Too often patients are actually embarrassed. They almost like look at me apologetically and say to me, I'm so sorry, I have notes, I apologize, it's going to take time. But it's really the opposite, actually. When a patient comes in writing down notes, it means that they took the time to think about what they need to say and what's important for them to say. And it actually makes the process go quicker, again, because I know that we can cover, and we're going to be sure we cover everything that's concerning the patient. So please write down notes as you go through before you come to your visit. When we're looking at what to write, like again, we talked about two different issues. One about your symptoms, and then the important questions that you should be asking your doctor. Now, when I'm talking about the symptoms, of course, these are questions that your doctor will ask you. So it's not about you, taking over the job for your doctor. But if you can think about what the information your doctor is going to want to know, it makes it easier to have that information on hand. It makes it easier for you to understand what the doctor is looking for. So when we're talking about your symptoms, and I've given a list of the common symptoms that a patient with inflammatory bowel disease may have, but let's say when you're talking about pain, pain is is not a very specific symptoms, and the way people describe their pain is quite variable. But those descriptive terms are really important for your doctor. So when you're talking about pain, you'd want to know, well, is it on the upper part of your abdomen or the lower? Is it on the right side or on the left side? Or what about how the pain feels? Is it sharp like a knife? Is it dull like a toothache? Does it burn? Is it crampy? Is it gassy pain? All these qualifiers are really helpful for your doctor to understand what that pain is really about. And so it's also helpful for you to, before coming to the visit, to prepare yourself to think about, well, what exactly is my pain? How would I describe my pain in better terms so that someone else would understand it better? Other information, like when did your symptoms start? A lot of patients will also not be clear on that. So in a sense, when you say, oh, it's been there for a long time, what does that really mean, a long time? For some patients, a long time means 3 days, while other means 3 years. And so having a little bit of a clear understanding of when they started is helpful. Same thing, how long do they last? 10 seconds is very different from 10 hours or 10 days in terms of understanding your symptoms. Do your symptoms get better or worse at certain times? Meaning, is it better in the morning or worse in the morning? What about at night? Does it wake you up from sleep? And also, does anything make your symptoms worse or better? So in a sense, like if you're eating, does that make it better or worse? If you move your bowels, does it make it better or worse? What about stress? How does that play a role in your symptoms? What about if you get a good night's sleep? Does that make your symptoms better? All these features are important to think about beforehand so that you can come up with an understanding, and you can actually look at what you do when you do get the pain, what may have triggered it. The problem is when we're not thinking of these things in advance, it's really hard sometimes to say to yourself, well, did it really a meal trigger it or not? If it was a meal, well, which food may have triggered it? It's easier to think of that in advance and take the time to think about it rather than trying to really decide on the spot during that visit what may have made things better or worse. And lastly, what treatments you have already tried. So if you take in, let's say, over-the-counter medications like a Tylenol or an antacid, or if you tried some dietary modifications, these are things that would be very helpful for me to know to help, again, to formulate your treatment plan and to understand the nature of your symptoms. When we're talking again for inflammatory bowel disease, there are specific other symptoms that are really important to transmit or to think about in advance. Now, most of us don't like to talk about our bowel movements. Again, it's something that patients always go, I'm kind of embarrassed to talk about, but realizing that there's no story about your bowel movements or your stool that I haven't heard. So this is the moment to really talk and get into those details because they're going to help to understand things. So how many bowel movements do you have per day? And of course, it's not going to be the same every day. So there's going to be a range, but 2 to 3 is very different from 10 to 20. And are they associated with pain or urgency? Meaning, do you have to run to the bathroom fast because you're afraid maybe you're going to lose the stool? what type of stool is it? Is it formed, soft, mushy, or liquid, or is there any blood in your stool? I know these details, again, sometimes seem gross, but they're really very helpful to understand things. And it's things that I'd like you to think about before coming to your doctor's visit. Also, how's your appetite? Is your appetite down because it hurts when you're eating? Are you restricting certain food intake because either it hurts when you're eating, or maybe you're worried about having diarrhea or gas? And have you lost any weight? Are you having nausea or vomiting? Weight loss for me is a very concerning feature because it's either going to be a sign that you're restricting too much or your inflammation is too strong. And of course, losing a lot of weight is going to affect your health. And so it's, of course, again, the doctor's going to ask you these questions, but if you thought about them in advance and also realizing, well, if you lost weight, how much weight did you lose? Because losing 2 pounds is very different than losing 20 or 30 pounds. And over what period in time did you lose that weight? Did it take only over a couple of weeks, or was it also over the last year? And that, again, is different information. How's your sleep and energy levels? Sleep is a very sensitive indicator, perhaps, of that you're having inflammation, or maybe you're just very stressed by the disease, or maybe you're having symptoms at night that you're not really paying attention to because it's not waking you up, but it's disturbing your sleep. And so you're being fatigued during the day. Energy levels during the day may be a feature that you're having inflammation that you may not even realize the level that you're having, but it's sapping your energy and causing you to be fatigued. And even more importantly, are you missing work or school or skipping social occasions? This is important because even if your symptoms are not that dramatic, at least what you don't think are dramatic, or maybe your doctor may not think it's dramatic, but if it's causing you to miss work or school, it means it's affecting your quality of life. And that means that it's also extremely important for you as the patient. And so if I know that it's causing that to happen, I'm going to be much more active and aggressive in trying to make sure that your disease is even better controlled than we think it was to get you back into work or school. One of the hardest things in a patient-doctor relationship is being open. There are topics that are just very sensitive, and it's hard for patients to talk about. But these topics are important to you. And you have to realize that also because they're sensitive, even though it is your doctor's job to bring up these subjects, because they're sensitive, even your doctor may be uncomfortable bringing them up. And that means you're losing out on the ability to talk about something that is important to you and something that may be clearly affecting your quality of life. So if you write down these notes, things that you know are important for you and that you need to talk about it, it'll increase the chances that you have the courage to be open and to discuss these issues. So that's, again, part of the writing in notes is not just about remembering, but reminding us and giving the courage to be open to have these discussions. Now, as your gastroenterologist, I may not be able to help you with these topics because I'm not, let's say a mental health expert. But if you bring these issues up, we can at least have the beginning discussion, and then I can direct you to the people that could help you much further. Which brings up also the concept, which is important in any relationship, is being honest. You need to talk about what really is bothering you. And because then your gastroenterologist can really bring up that concern and direct the treatment or discussion to it. There's been times when I've had a patient and I've just, I look at all the results and see everything's going well. There's no issues, there's no problems that I can see. Be it I'm looking at my patient and they still seem worried and I'm not really understanding why are they worried. And it's only by asking them that question, really, what is still bothering you? Is there something you're still worried about? And they may say something like, well, do I have cancer? And in my mind, that never crossed it at all, because I never thought that cancer was even an issue in their problems or symptoms or in any of their test results. But that is what was bothering him. And until I kind of addressed that and said, no, there is no cancer, they were going to still go back worried that they may have that. So it's really important to be honest and say what is bothering you the most, so that, again, we can have that discussion and that we can direct treatment towards it. So that was talking about your symptoms. And again, we talked about the dossier of the past that you should be bringing in. But it's also important to write notes about the questions that you should ask your doctor. Because again, in the heat of the moment, when a lot of information being transmitted, it's hard to remember all the questions that are important. And again, sometimes patients are either shy or embarrassed to ask questions that are important and that they need answers to. So these are kind of the questions that I feel that it's important to have a discussion about. And the first is, why was this treatment chosen? And again, when we're talking about treatment, I don't mean just medications. It's the whole treatment plan. So the questions being, why are we doing a colonoscopy? Why are we asking for a CT scan? Why is this medication being chosen? And which begs the second question, are there any alternative options? Could I do a stool test instead of a colonoscopy? Could I do an ultrasound instead of the CT scan? Could I try diet modification or alternative healthcare options rather than taking this medications? In a sense, getting your doctor to compare them. And it's important always to realize that there's always options. So, but there's sometimes good options and sometimes not so good options. And it's important for you to have that discussion with your doctor to decide what options are best for you as an individual. What is the success rate of the treatment? And that's also very important, because this is about driving kind of reasonable expectations. No treatment is 100% successful. And it'd be a shame that a patient would think that and then be disappointed. But considering that a lot of our medication treatments, really their response rates may be initially 60 to 80%, but overall at the end of the year, it's about 30 to 40% success rate. Which is much better than not being treated, obviously, but it's important to think about that and realize that the success rate may not be as high as you want it to be. What are the potential risks or side effects? Clearly, this has to be discussed and they have to be weighed. And of course, you really want to look at the most important side effects, not all the smaller ones, although those discussions can take place as well. How long will it take for the treatment to work? This is often, even sometimes as a doctor, I forget to discuss with the patient, but it's actually very important, because if let's say that a treatment's going to take 2 months to work, well, you're going to be patient for those 2 months until it does start to work. But if you're told it's only going to take 2 weeks to work, and it's now 4 weeks into the treatment and it's not worked, then you clearly understand that you need to contact your gastroenterologist and say, hey, my treatment's not working. What are we going to do now? But if you don't know how long it's supposed to work, you're either going to be taking the treatment too long, or you're going to be starting to get disappointed too quickly. So it's important to talk about that. Also, how long will I need to stay on the treatment? Most patients are often not realizing that the treatment plans that we put into motion, especially some of the medications that we use, are going to be months to years. And that may impact on how you feel about the treatment as well. And lastly, what would happen if I didn't take any of the treatment? We so often talk about the risks of a colonoscopy, the risks of some of our medications, but we don't often talk about, well, what are the risks of not doing the colonoscopy, not taking the medications, which can be much worse than the risks of the treatment itself. And so you have to weigh those different options. Sometimes I joke with my patients when they talk about, worried about the risk of some of my medications. I asked them, well, were you worried when you got into the car to come to this treatment? Were you worried about you're getting into a car accident? Because statistically, you are at higher risk of getting into a car accident than taking the medication that I'm going to be offering you. So we always have to weigh, again, good options versus bad options and think about the risk of taking treatment versus not taking treatment. And also, all these issues are important in the discussion because patients have different agendas when they're coming in to the discussion about treatment. For example, if a patient has, let's say, minor symptoms, they're not so severe, that patient may be willing to take a treatment that may be a little less successful or may take longer to work, but has no side effects because they feel that they have the time to take the chance on an option that may not be, that at least doesn't have any risks to them. That's going to be very different from someone who's very sick. Let's say someone who's hospitalized, where the need for speed is strong and the need for a highly successful treatment is strong because we need to get them better and out of the hospital quicker. So they may be more likely to take on a higher risk medication to have that higher success and to have the speed of treatment. So in these two patients, they're going to have very different treatment plans, but it's not a right or wrong option. It's really about what's best for them. And so the more that you think about these issues prior to your visit, the more that you have these questions ready to ask your doctor, again, you're more likely to have a treatment plan that is suited for you as the individual patient. Now, even though we do have a treatment plan, we have to know, what does it mean that the treatment is working? How do we know that the treatment is working? It's not just how long it takes to work, but how do we decide that it is working? And here's again, we need to match the agenda of the patient and the doctor together so that we both understand what we're each looking for in deciding whether the treatment is working. And obviously, we want you to feel better. And of course, you want to feel better. But really what we want you to do is to feel normal so that your life is perfectly normal with no issues. But as physicians, as your gastroenterologists, you feeling normal is actually not good enough for us. We want to be sure that there's no inflammation at all. Because we know that if we can get rid of your inflammation completely, we're going to be keeping you feeling normal much longer. And it's going to maintain that remission that we've got you into for a much longer period in time. So there are going to be things that we do for you or ask you to do that has nothing to do with whether you feel normal or not, because we're going to want to check and see if there's no inflammation. And this is important for you, again, to understand. Then there are a variety of things that we may do. We may do blood tests, stool tests, again, X-ray imaging or colonoscopy to follow you. And it's why it's important for you to know that, because if these discussions didn't take place, if your doctor didn't tell you how we're going to follow you, it's really helpful if you just simply ask, well, when are we going to do the next blood test? When are we going to do the next stool test? How often am I going to need to do a colonoscopy? What is going to be the indication of when we're going to do a scan or a colonoscopy or a blood test? And so this is an idea of having your treatment plan all set into motion so that you know exactly what's going to happen, not just this visit, but what's going to happen before the next visit. What are you going to need to do to prepare for your next visit? Are you going to need to get a blood test or a stool test ready before the next visit, and how many weeks before the next visit so it's ready for that you're prepared? The last thing I wanted to talk about is the fact that, just to remind you that your doctor is a person too. They're not gods, they're not infallible, and they suffer the same stresses and issues that you do. There have been times when, I've been called to the emergency room at 3 o'clock in the morning and have to be back in the office at 8 o'clock. And I'm sure I'm tired, but I still have to do my job. Same thing, I may be in a discussion with a patient that could have been a very emotionally difficult discussion. And I have to step out of that room, put a smile on my face, and, come back, and see the next patient, and hoping that I won't be distracted by that. So when we both realize that we're all people and we're all working together to try to make you better, we remember that the doctor-patient relationship is an important feature in your health. And the stronger that we make that relationship, the more likely that you are going to have all your issues discussed, and the more likely that you're going to be on a path to better health. So to summarize, a good patient-doctor relationship means that both are invested in making it work. So being prepared is crucial because it tells your gastroenterologist that you're invested in your healthcare, and it tells and it helps to make the process towards your diagnosis and treatment plan smoother and easier. Be open and honest. This is your chance in that visit to talk about the things that are important to you. Once you leave that office, that visit is over. And it would be a shame to have you being left there with unanswered questions and unanswered concerns. So try to be open and honest and write down these things so that you have more courage to talk about them. And lastly, ask the questions, and most importantly, expect the answers. This is what the whole point of this relationship is for you to feel that your concerns and questions have been answered, and that when you get these answers, that you understand these answers, and that you make sure that you understand the answer to these questions. Thank you again for Crohn's Colitis and the Jaclyn Fisher Foundation for inviting me. Again, I'd really appreciate any thoughts on how to improve the doctor-patient relationship, or any thoughts about this, this talk. You can email me at ourdigestivehealth@gmail.com. And again, like I mentioned earlier, if you want to check out my website for some basic information about your digestive health, you can check it out on ourdigestivehealth.com. Thank you so much. If people have any questions, I'd be happy to answer.
Hi, Doctor. Yeah, Dr. Friedman. I'm just I don't see. I know you've answered. You've responded to a lot of the questions. Does anybody else have a question? Somebody had asked a question about writing down their questions prior to the visit, that often patients are anxious during the visit, so it causes them to forget things. Does anybody on the French side have any other questions for Dr. Friedman? Hold on, I see some. No.
There is a question from Eva. So she's a nurse for patient support program, and she's wondering if you can suggest anything that we can do to better support our patients and their physicians.
Oh, interesting question, because that's from a whole different perspective. I think for me, it's about education fundamentally. And this was an education about how to prepare for your visit. But I think where nurse comes along is helping, I think, the patients understanding their disease better, understanding their medications better, understanding the whole process of healthcare better, and how to navigate through that. I think that's where nurses can often act as great liaisons between the patients and the physicians in terms of guiding the patient to how to manage their physician appointments and manage the healthcare system in general. That's what some of the company liaison programs, again, for some of the medications, have really been very helpful for patients in terms of giving them the education about the medications, about their disease, and assisting the physicians in managing the medication program.
Thank you very much. Are there any other questions from the audience? Yes. So everybody's thanking you, Dr. Friedman. It was a great presentation.
Yes.
And
thank you so much, Dr. Friedman, for your time and for joining us this morning. Okay.
If I can just mention, actually, for everybody who is online now, our participants, please use a laptop or computer, because on your phone, you won't be able to have the viewer options in terms of selecting presentation in English or in French. So please use your laptops.
Rena has another question for you, Dr. Friedman. Although your time is limited, she's wondering what help you have to support patients and nurses. Is there any kind of help? I can't hear you. You're on mute. You're on mute. Sorry, you're mute.
I think, though, here's where I have to admit that Crohn's Colitis Canada has excellent support group, and if anyone has not looked at their website, I'd really suggest you doing it. My website is pales in comparison to the Crohn's Colitis Canada website in terms of inflammatory bowel disease specific information, and really about a lot of the issues that confront patients with Crohn's disease and ulcerative colitis. So I'd really encourage people to look at that. And I mean, I link it in my website, but it's really easy to go on it, and it's quite extensive, quite detailed, but really written very well for patients. And I think it's good for not just for the patients, but again, all the support staff, nurses, therapists, and physicians. I've looked through it as well, and to help me how to talk to my patients. So I would really encourage people to use that. There are other sites, but again, the Crohn's colitis one is quite valuable.
Okay, well, thank you so much, Dr. Friedman, for your time and for your wonderful talk. I don't think there's anybody else with additional questions, but you know how to reach Dr. Friedman. He provided information, and we'll provide his contact information as well to anybody who didn't take that down. Okay, so we're gonna take 10, what?
Thank you again.
Thank you so much for your time. Thank you for the great talk. And we're just gonna, we're going to have Dr. Dean Tripp on at 10 a.m. So if anybody needs to take a little break for a few minutes, we'll be back on at 10 o'clock. See you soon. Thank you.
Hello, everybody. Bonjour tout le monde. Okay. So right now, thank you very much for joining the second presentation of the day. Thank you very much, Dr. Tripp, for offering your time. And now I just want to make sure that everybody is able to use the translation services. So if you select, in order to use the translation, you need to select the interpretation button at the icon at the bottom right of the screen. And this way you can choose either French or English option, depending on which one you want to hear. And on the top of your screen, you're going to have view options. When you click on it, a drop-down menu will appear. And you make sure that you click shared screens and select English or French, depending on your preference. Donc, pour nos collègues francophones, tout d'abord, je vous invite à cliquer Interprétation en bas droit, à droite de l'écran, et puis sélectionner la langue de votre choix, soit l'anglais, soit le français. Mais dans ce cas-là, ce serait le français. En haut de l'écran, vous pouvez visualiser les options, donc View Options. Puis quand vous cliquez là-dessus, il y a un écran partagé, donc afficher les options, et écran partagé apparaîtra dans le menu déroulant. Donc de là, vous allez sélectionner le français. Parfait. Comme ça, vous allez aussi voir les diapositives en français. So, some housekeeping right now. We want to really encourage you to keep your microphone and camera off. And also, we need to absolutely make sure that you use your computer, because we're unable to have viewing slides in another language if you're using your phone. If you experience any kind of issues with technical problems or with Zoom, you have three options. So first, you can refresh the page or the browser. Then you can also, check the handout, troubleshooting tips that is sent to you by email. And lastly, you can also write in the chat. On the bottom of the screen, you see the chat, and you can message privately French for any technical issues, and you'll be able to be assisted. If you have any questions, feel free to write them throughout the presentation in the chat, and they'll be answered in the Q&A at the end of the session. So we'll collect all the questions, and the moderator will ensure that the presenter will answer these. So just note that the webinar is recorded, and we will send you the link to the video by email, and it's also going to be posted on our site. And last but not least, we are going to send you a participant survey to make sure we improve our further education sessions in the future. And now I'm going to present to you Dr. Tripp, who is a full professor in the Department of Psychology, Anesthesiology, and Neurology at Queen's University. And he's also the current chair of the Queen's General Research and Ethics Board. And I'm going to allow Dr. Tripp to present himself and in more detail.
Well, thank you very much. First, I'd like to thank Crohn's and Colitis Canada for this opportunity, and of course the Fisher family for allowing me to be part of this great event. And I'm excited to talk about our research. I'm excited to talk about what our patients have told us about their conditions and their life experiences. So that's what I'm going to do today, is tell you a little story about what patients have told us. So I have a little lock up on my screen here. Let's see. Okay, there we go. It's a little slower than I'm used to, that's all. Zoom. So there's a disclaimer. Go through that pretty quickly. And here's some potential conflict of interest to some of my consulting work that I've done in the last year or so. And this is a crazy picture of me over there in the corner. It says I'm a prof at Queens, different departments, probably because, and GI should be up there now, but it's not yet, because I've been involved with research that is focused on pain predominantly and psychological distress from painful situations. My psychology, anesthesia, urology, and GI work follow suit in that area. As mentioned, I'm the chair of the General Research and Ethics Board as well. I do some other consulting outside, you can see there. I've published some research, I do chapters, I'm involved with a lot of pain education events, and I've been awarded some stuff, which is great. I love to get rewarded every now and then. And my primary research is focused on pain, as I mentioned earlier, and psychosocial factors, and how people try to manage that. I mean, that's my bottom line. I want to understand how patients tell me they best manage things and how they worst manage things. I mean, that's the basic idea of my last 20 years of research. So this is my title slide. And really, when I was asked to talk today, I thought, the one thing that I believe has to be a large statement in our community and in the research community and in the health community, period, across Canada, is that IBD mental health research is essential. Not only is it important, but it's essential. It's essential to care. And I'm going to present to you some of the reasons why I think that's true today, and why I continue and my research lab continues to be productive in this area, because we believe it's a bit of our mission to kind of help IBD patients.
Hi, Dr. Tripp, just to interrupt you, are you sharing your screen? Because we don't see your screen.
Oh, I am sharing it. It says I am.
Cindy, I do see it.
I see the French only.
Okay, no, I do
sorry,
see it.
I just want to make sure everybody sees the correct thing. Okay, thank you. No, sorry to interrupt.
That's okay. I thought I was sharing it. If not, let me know and we'll figure it out. So I'll back up one. This is me again, and just saying how important I think mental health research is essential, how essential it is to healthcare. So the topic I want to invite you all to try to figure out today is this thing called psychogastroenterology. And for me, this is a term that's relatively new, but I think a term that I want to start to get out in the public. I have colleagues in the US who have been talking like this for the last couple of years, and I think in Canada, it's time to start putting a handle on need in terms of psychosocial support for our patients. And when we think about what a psychogastroenterology person might do, I want to talk about three particular areas today. I want to talk about IBD health-related quality of life. I'm going to talk about patients' quality of life and some of the predictors involved with that in terms of poorer quality of life in particular. I want to then talk about a specific psychotherapy that we developed in our research lab that we used and developed this along with some patient input as well. But we used in a small pilot study to try to see if we could have effect on some of the areas that patients were telling us needed some attention, but were not really being serviced. And then thirdly, I want to talk about a brand new study that we've just published this year in 2020 from our lab as well, that deals with that dark subject of suicide and suicide risk in patients with IBD. So that'll be a little bit of my talk. And I want to present these areas because they're wide in focus. And that's exactly what I want you to understand the term to be. When we talk about psychogastroenterology, we talk about the psychological impact that disease has on the person. So what is this term? Well, basically it's this idea that you as a psychologist or a healthcare provider are going to work in with this construct or this area, and you're framing your work within sort of an evidence-based psychological intervention that has applicability to digestive conditions. So what I'm basically saying is we want to make sure that when you're working in this area, you're specific to GI concerns. The other thing is that I want to make sure that you understand that the psychologist would not work alone. They would work with the context of a team and have that application in that manner. So here's a little graphic that might help me explain this. So when we think about the population of people, and you can see here, you know, hopefully you can see my little mouse on the screen now, but this is kind of like the population of people with IBD, let's say in Canada or your province. And you can see that we have orange types, a little shorter, we have green, yellow. What these are is they mean that they may be different types of people in different types of situations. And you could see here, so green people, they might go here and have the most severe symptoms. So they might be sort of triaged, if you will, to see this person with this setup, with these specific skills to help with this situation. So this would be the more severe bowel symptoms, higher impact on your quality of life and so on. Then we would have the yellow people kind of triage to see sort of the general psychologist, which would mean, you know, mild to moderate bowel symptoms, more relatively manageable than severe. Your impact on your quality of life is there, but it's not at a level that is destroying you, as people have told me. And I think you're a little bit more functional. And then we have down below, sort of we would call the red or sort of orange people here. And those people there would have another issue. They would be in the psychiatric issues. So then I'm going to talk about suicidal ideation today and some other sort of comorbid conditions that would make this a red zone. So when we think about the different ways that psychogastroenterology would interact with patient groups, I think it's about need. We call it triaging or kind of, but I just basically say, what do you need? And I think we need to have levels because not every patient is the same. Not every patient experiences their symptoms the same. So I think we have to respond to that. And I'm suggesting this format works from my perspective, at least. So I want to talk to you a little bit about quality of life because I've mentioned this a couple of times. And one of the things that we did when we were looking at this research project, and there are 3 different studies I'm going to talk about, is we talked really about pain, first of all, because that's what was my primary interest coming into looking at patients with IBD. And we know that there's a lot of pain across IBD. And we know up to 90% of patients report pain that can't be explained by biological markers of the disease. So we know that. We also know that sometimes when you're in remission, you can still have pain without symptoms. And that's something that can leave a significant impact on an individual's quality of life. We know that. The research is clear. The patients have reported this, so we understand that. So in this study, we wanted to know what factors could explain the relationship between pain or some disease activity, I just refer to those as pain, and later quality of life. And this is important because this really has not been studied or applied in IBD research before our project. So our objective was simple. We just want to use a study design that's going to allow us to follow people over time, call this a longitudinal model, to just examine the relationship between pain at like time 1 and health-related quality of life at a further point down the road. So what influences this relationship? Because we know it exists. So high pain creates a poor quality of life down the road. But what might be factors that sit in between those things? What might help us understand this? So we asked patients and we designed a survey that would allow them to give us feedback over the course of time. So here's what we found. And in this diagram here, I just call it a picture. We have time 1, which would be T1, which is pain. And of course, all the way over here, we have T3, time 3, which is health-related quality of life. Because we assessed these patients at 3 time points, okay? So in between, at time 2, we also did an assessment and looked at a couple of factors that are supposed to be associated with worse pain and also with worse disability, if you will, which would associate with poor health quality of life. And what we found, see, what's important in this diagram is really look at the arrows that are solid. Those are the ones that show the relationship that we found in sort of the statistics. These dotted ones, they just don't mean anything at this point. So what this model basically says is that pain creates greater catastrophizing about your pain, and catastrophizing really is what everybody does all the time. But in particular, whether you're a patient or not, people catastrophize all the time. And basically, pain catastrophizing is about specific sensitivity to pain and how pain can really be scary and make you feel anxious. So we know that if you have a lot of pain, it can create helplessness and rumination and kind of really make you think about pain in a negative way. And that's really what this relationship shows. So we know that happens. Then we also found that this sort of pain anxiousness creates what we call illness-focused coping. And this is really interesting because illness-focused coping is things that you do behaviorally when you're in pain. So like you have excessive guarding of a pained area. You take a lot of rest, more than you might need for that, and you ask for a lot of assistance. So in other words, if you're in a lot of pain and you start to get really anxious about your pain, what you tend to do is you tend to do things that mimic that kind of negative cycle that you're falling into with your pain. And then we know that these in combination create a poorer quality of life for our patients. So it's this kind of pathway going across time that our patients are telling us, look, this is what happens to me. I get a lot of pain. I start to get really anxious and worried about it, feel a little bit helpless. And then I start to do things for my pain that don't help me. So I excessively rest. And then I can start to feel sedentary and feel bad about myself. I'm asking for way more assistance, and then I feel like a burden to other people. And that reduces my health quality of life overall. Disability would also come into this play as well. So we could say I feel more disabled and my health quality of life drops. So this is a really interesting study because no one's looked at those pieces in that way. And we're very happy to say that this paper's in manuscript form right now and about to be sent for publication. So this is brand new information from our research lab. And you can see below Dr. Bayak and Ropoleski as well from Kingston, KGH, the hospital in Kingston are also part of this team. This takeaway is simple. The results tell us that greater pain predicted early increase the level of fear and sort of helplessness, we call this catastrophizing, that people might have with that pain, which in turn leads to coping that leads to poor quality of life or decreased quality of life at 1 year later. So this model basically suggests that pain has this indirect effect, if you will, on your quality of life through your thinking and your coping styles that get changed by pain. It alters that. So it's kind of like a stress diathesis model, which means pain creates this problem, which then creates this problem. So we're very happy to see all the patients that engaged in that. We're very thankful, and for the comments that they provided in the research as well. One of the things that I want to leave on this slide, I'm going to talk more about this in a second, is that it takes effort to learn, but you can identify these thinking styles and you can identify the coping behaviors that are best for you. Like I say, every type of coping is coping. I'm not going to call it bad or good. I'm going to leave that up to the patient to say if it helps me or if it's worse for me, if I try to do one form of coping versus another form of coping. So we'll talk more about that in a second. So the next study I want to talk a little bit about is an IBD group therapy study that we did. We basically said, look, we know that there's lifestyle adjustments needed in any chronic disease. So we thought we'd look at what influences well-being. And what we found when we looked at the research on IBD psychotherapy is that the outcomes are pretty inconsistent, which means some are effective and some are not. And some work to, are not effective at reducing anxiety or mood. We thought that's important. And some seem to improve quality of life and others don't. So we really wanted to say, what about these other things? So what about fatigue, disease relapse, hospitalizations? Those can be improved somehow through hypnotherapy and a variety of other sort of available approaches. But then we start to say, okay, our objectives have to be a little bit bigger. So not only did we want to develop a therapy that's in what we call cognitive behavioral therapy, or, a very, evidence-supported way to kind of approach these problems. We wanted to use a self-management approach where the patients were in control of the therapy. And we wanted to do this in a group therapy setting because we thought that kind of sharing experience could be really positive for patients. So basically in developing this program, we did a couple of things. And I want to just point out this here, this kind of ABC model or ABCD model. And I call this cognitive restructuring or just changing the way you see the world. And this is really kind of neat. And I'm going to talk about what that is so you have a sense of it in a second. Basically, the other key things in this study is we put a manualized protocol together, which means patients got a manual to take home, almost like a book. And we did it as I mentioned, a self-management approach. And we screened patients coming in to make sure that they, I guess, in lack of a better term, had enough distress to need the therapy. Because you can't, if you put someone in a therapy situation and they really don't need it, you're not going to see any kind of help with that. So we did those sorts of things and we launched the project. I said I would talk about the ABCD. I want to just give you a little, and this is very quick. I apologize. I could spend way more time on this, but basically today I just have a little bit of time to talk about it. If you think about the alphabet, this is what I think about thinking and how your life operates. A is like an event or an activating event in your life, which is like a trigger or a situation. And I'm going to show you an example of that in a second. B is your belief. C is the consequence that happens because of that belief. So I'm going to give you an example of this, and D is dispute. So A, B, C, and D. When you have the chance to read through these slides, you'll have a sense of, oh, maybe that's how it works. But let me show you what I mean. So if we think about catastrophizing, which is one of those sorts of situations where, the person is, forced by pain or some other life events that are happening to them, those triggering events, those A's, to think about the worst possible outcomes, which is B, which is your belief or your thoughts. So if you think about the worst possible outcomes, how are you going to feel? Let's go through an example. So this might happen to you in your life every now and then. So if you can't reach a loved one on the phone, you suddenly start thinking that something bad has happened to them. Okay? So you're thinking about maybe the worst outcome. So what can you do about that? Well, number one is you can ask yourself, what proof do I have that the worst is actually going to take place or has taken place? Do I have any evidence, or is it just a feeling? Am I just afraid? Am I just being anxious? That's a great question, because if you can pose that question to yourself, when you start to feel that kind of rush of like, oh my gosh, something terrible has happened or something terrible is going to happen, this is a really classic thing to try to do. And we call this stop thinking. So you just stop thinking and try to be rational about, is there evidence for this? So that's one way to do it. Another way is to allow yourself, and I like this because I think it's more fun, is to allow yourself to play out the worst case scenario. So in red, you can see here, they're saying, look, my loved one is not answering the phone because something bad happened to them. So you can actually say that, maybe that happened, right? Then I want you to go, well, what's the best possible scenario? But unlikely scenario, perhaps. My loved one won the lottery and they want to come home in person to break the news to me, so they're not answering their phone. Now that may not be logical, but I guess if the worst possible thing could happen, I guess the best, maybe unreasonable possible thing could happen that's positive. And then I want you to go to the middle. So then it's like you've talked about the worst, you've talked about the absolute best, and now you're like, okay, let's get more realistic or more rational about this, find a middle ground and say, okay, my loved one's phone is on mute, they're in a meeting, or they're driving, or they lost their phone, they'll be home soon and I'll see them. So this is kind of like a step to try to avoid some of that really tough thinking that we get stuck in, that anxious feeling that can make anxious beliefs, that can make you feel helpless. And this is what I work on when I talk about catastrophizing, where I talk about that anxiety with pain in particular. So let's get back to the therapy. So we did the groups and we had 8-session format. And what these slides basically tell us is that the patients in our groups, in our little pilot study, reduced anxiety significantly over time, okay, in the treatment group. And you can see here the blue is a treatment. We also tested shame, which has not really been tested much. And we showed again that we can reduce that significantly for our patients over 8 sessions. And then I did something that was a little bit different. I said, I don't want to talk about pain particularly. I want to talk about catastrophizing in regards to your life. So being anxious and feeling helpful in your life. And that's a really interesting way to kind of look at that term. Instead of taking it just to pain, I took it to life experience. And we see that our program was able to decrease that significantly over time for our patients as well. So there were other indices that didn't quite work out that I don't have time to show you all the sort of the negative findings, but these 3 significant findings alone are enough for me to say, look, we need to go forward with this, retool this therapy and get it out again. So that's our plan in the near future, but this pilot I think was successful. So the takeaways from that therapy are basically, look, let's adjust therapy programs, to include previous studies and data. So like body image, stigma, shame, social support, these things need to be included because this is what patients say are important. So that's for future research for sure. And when we think about the results here, like I mentioned, some will be close to being significant or not. It's a numbers game. And if we had, conducted a real randomized controlled trial, then we might have had far more patients in there. We'd have been able to make far stronger statements about the variables. But at this point, given the pilot status, we can't quite confirm what was there for the other variables. And then this catastrophizing in terms of your general life is a new factor. And I think that's something I'm very interested in because it is about helplessness. And I want to talk about that again, because I think that's really what it is. Patients describe, when the term is catastrophizing, but I think patients really are describing helplessness and anxiousness. That's what I think I'm hearing more when I talk to patients about it. So we want to think again about how catastrophizing might be involved with social embarrassment. We might want to think about other situations that can create real anxiety here for our patients. So again, it's in my head now about moving forward because patients have told me these are the way they experience their lives. So I want to turn to this other study that we did very recently and just published in Journal of Health Psychology, and it has to do with suicide risk. Now, we know that IBD is debilitating. We know it's a chronic medical condition. We know it affects a lot of people. The thing that you might not be aware of is that EpiData basically suggests that suicide behavior is a concern in our IBD populations. But to the point where we were looking at this, examining this probably about a year and a half ago, maybe 2 years ago, suicide risk in terms of ideation attempts in this population has not really been flushed out. So when we looked at the literature, we weren't very happy about this. Dr. Bayak, Dr. Ropoleski, myself, people in the Imagine Network, people I met through CCC, we're having discussions about this. And I said, look, we need to do better. So we need to go figure this out as best we can right now. So I wanted to look at the link between IBD and suicidal behavior because it was limited and the findings were mixed. So our objectives were, I thought, pretty straightforward. Number one, identify prevalence. So how much people report this suicide risk. And number two, let's try to put a roadmap in where we can understand how some of those variables are impacting suicide risk in our patients. To me, if we know that, we can intervene. So here's the roadmap that we came up with, or the picture, if I can say this. So I'm going to start at the beginning. We're going to go really left to right. And I'm going to present it like that. And there's other ways I could talk about it, but I think this is the sharpest way to do it. So in this sample, what we found is that IBD symptoms obviously are going to be related to higher pain and greater shame. So these are two things that we found from earlier studies that are copied again in our current study, and that we have a sense that higher pain and greater shame of symptoms and your bodily experience lead to more depressive symptoms. Again, this is something we hear a lot about in IBD. I see it a lot on blogs. I see it a lot on Instagram. I see it on posts from patients. I see it when we talk to patients. So this connection makes some sense for some of the experiences patients have. But what we wanted to do is take this and say, look, we know that depressive symptoms can lead to suicide risk over here. But what about these important pieces that the suicide literature talks about that have not really been tested in IBD patients? So we went out and said, okay, we're going to look at hopelessness. Remember I was talking about helplessness earlier? Hopelessness is akin to that. Psychache, which is another very interesting variable, which basically is psychological pain. So you have physical pain, but patients who get to this stage with deep depression will often talk about having a pain that's psychological, that they can't put words to, but that they experience. And then something down here, PB, which is perceived burdensomeness. And that's hard to say, but you see yourself, you perceive yourself as a burden to other people that you love or other people that are in your life. So what we found from here is that depressive symptoms, when they are high, leads to greater psychache, also leads to greater perceptions of being a burden to other people in your life, and also leads to greater hopelessness. Now, if you look at this, it's complicated, right? Depression leads to psychache. It also leads to perceived burdensomeness, but it also leads to the sense of hopelessness. And this might be the vehicle in which this travels from. Hopelessness is a key factor, again, that drives psychache, drives this sense of burden that you are to other people, that you think you are to other people, which may not be entirely true at all. And these two factors here, not hopelessness directly, but these two factors there increase the suicide risk in our patients. So this story, if you will, is told to me by my patients, by our surveyed patients that gave their time to tell us about their life story. And this is not an easy story to tell. The other thing that's really important to note here is that when we look at the numbers, I told you we looked at prevalence as well. Let's look at this. Almost 41% of our sample indicated clinically significant suicide risk compared with an adult general population. 41%. So I'm gonna talk about that in a second, but this is the picture. Symptoms can lead to suicide risk. It doesn't mean this happens in every person, but we now have a bit of a roadmap that I think can inform clinical practice and also raise the alarm that about 41% of this sample was in definitely need of some help. And I think that's an important statement. So I'm going to move on from here. I'm going to talk about the takeaways. Number one, 40% of the individuals in this sample were clinically at risk. That is something I can't stress enough. It's way too much for me. If there's 5%, I think it's too much. But 40 is out of this world, and I really am going to follow up in this research. We're going to try to do as much as we can to make that different. In comparison, if you just look at other sort of samples of patients, the prevalence of suicidal ideation, let's say fibromyalgia, is just greater than 30%, and ranges between 8 and 34% have been presented for patients with lupus. So if we think about other conditions which are quite concerning, quite taxing on patients, it seems that based on this sample, based on this prevalence, and we'd like to see more data, that about 40% of our patients are here. So we're in the ballpark of having a very negative experience reported by many of our patients. And, I think this is a call to action. So new targets that come out of this research for me are clearly psychache, this concept of mental pain that I was talking about, and that perception that people are a burden to others. And we know that that makes you feel helpless. We know that that makes you feel like you're worth less. And we know that that just really adds to depression, that you think you're hurting other people. So these are types of things that I want to target in the future. And I think clinically that we need to be thinking about as people who intervene with patients in distress. So this research for me is an eye-opener, and I'm happy to be able to share this with you today. So my wish, I have a wish list. I guess it's almost December. Everyone's starting to think about wish lists. My wish list is a little bit different today. My wish list is about what I want to see happen. My first wish would be that the critical psychological symptoms and those mechanisms I talked about, like psychache, about that burden, about, catastrophizing and how people try to cope and manage. I would love that information became widely acknowledged. So that's why we're trying to publish it. I'm so happy to present today. Thank you for the opportunity. I want everyone to know about that. That's my first wish. My second wish is that these mechanisms, these problems that we're identifying at our lab at Queens, I would love to see that being assessed in practice more regularly by physicians, by nurses, by healthcare practitioners who are working with our patients. And my third wish is that these types of symptoms, these types of mechanisms are getting treated in IBD. So those are my three wishes for this year. Those are the wishes that I think create the mandate for me going forward in my science and in my research and in my interaction with patients. Those are going to be my wishes for the next year and probably years beyond, because I don't think there's a simple solution or a quick fix. What I also want to take is a quick opportunity to say, look, we talked about pain in terms of quality of life, and we know that pain is so important in driving negative psychological experiences for patients. And this is available for you. You can go here, and for more information and strategies to manage pain, you can visit crohnsandcolitis.ca/pain, and you can see all these resources here. I was part of the group and the committee that put this together for you, and I really think we did a good job. I'm hoping you think we did a good job. But if you access this and you use some of this and look at it, you might also be able to help us upgrade it and make it better. So this is something I'd like to see you all get a piece of and see if it can be helpful for you, because we hope that it is. So that, again, you can get that at the Crohn's and Colitis website and /pain. So I think at this point we go to a Q&A period. Now I'm not sure if they get read to me or someone tells me about them, or I should stop sharing my screen. Someone let me know how we'll do the
Yes,
Q&A.
I will. Hi, Dr. Tripp. Thank you
Hi.
so much for that amazing presentation.
Thank you.
I learned a lot, and your research sounds fascinating. And we actually have one of the a nurse here who said that was an amazing study, and
Thank
she
you.
has seen that constant pain causes depression, frustration, and a sense of hopelessness. And she was wondering that it's been said that serotonin levels are often affected by IBD, and does that contribute to patients' anxiety?
Yeah, that's a good point. That's a very good point. And I think there is definitely associations between serotonin and mood. We know that. So, and if IBD, and what I'm gonna say yes to that. There is a connection, first of all. Secondly, you're starting to make me think about the microbiome research that's being done that looks at the impact on neurotransmitters from gut flora or the microbiota in your microbiome or in your gut. So when we look at, and I'm no expert in that area, so I don't want to start going down that path, but there is some really cool research out there that's being done and supported by Crohn's Colitis Canada that's looking at the microbiome. And I think that over the next 5, 6, 7, 8 years, hopefully, we're going to have some really cool science that's going to be able to say, look, there might be a way to change that relationship between IBD, sequelae, and the outcomes of lower serotonin. So absolutely, there's two answers to that. Yes, there is an impact. And yes, I think microbiome research coming up will be helpful in targeting some cure there, or at least some way to mitigate that. It's a great question.
Thank you. Another question was that do you have a network, or does there a network of mental health practitioners exist who are collaborating across the country to enact the therapy program that you've developed and provide the care outside of the research setting?
The answer to that is no, not yet. So what we want to do is it's coming. This is in my, my wish list is we want to go back and we want to take a couple of pieces of the research therapy that we did. I'll call it research therapy, but the therapy that we did. And we think there's a couple of pieces we can sharpen up based on patient feedback so we can have a better effect. And then we're going to do that. And then we want to go to another trial of it. But because we have pilot data suggesting there's evidence that it does have impact, we're going to have to make a decision on whether we try to manualize it and get it out and provide training, which is something I think we can do, and then look at maybe some sort of collaborative approach across Canada. I'm involved with the Imagine Spore Network group, which is a large research group sponsored by the CIHR here in Canada. And that's one of the things that we've been talking about back and forth is like, what are the next step? How do we get this to the market, so to say? So it's like we have something we think is good. We just want to make sure through patient feedback, we want to honor that. And then we want to make sure that what we've got is the best thing we think we can produce. Then we want to put it out. And then I want to put it out in a way where patients, again, can give me feedback. So I've been thinking about trying to do it virtually instead of having like patients have to come into the hospital and do a group thing. The COVID situation's got us thinking very pragmatically. I think if we can do it virtually, even if it's one-on-one individual and have it all kind of programmed in, maybe we can have that set up. So our head is spinning about application and how to get it out. But yes, trust me, we are thinking about it and we're going to try to put out something that will work. I am also working collaboratively with people in the Maritimes, with people sort of across Canada, all the way out to the West Coast. So I'm hopeful that we're going to be able to implement that. But that said, there are centers that I know of, like in Toronto, like at Sick Kids in particular, and other places like out in Manitoba with Charles Bernstein and Leslie Graff that are doing some great stuff as well, including some online approaches to psychotherapy approaches. So I think together we'll come up with the right formula, but having more available than less is what we want to have. So it's not quite ready, but trust me, we're going to be working towards that for sure.
That's great. Continued from that question. How do you suggest patients who are in psychological distress, I was actually going to say that, get their mental health professionals to engage with them in these IBD specific factors, as most healthcare practitioners are not sensitized to these specific issues?
Yeah, this is an issue. You know, it's kind of like I'm always reminded by whenever I try to change anything in my life, it's never been easy because I don't ask for small changes, right? I come up here today and I say, I want massive changes. Like the changes I'm talking about are not going to happen immediately. That's for sure. It's kind of like when you're on a boat, you know, if you've ever been out fishing, you're in like a 14-foot boat and you want to turn around. Well, that's pretty simple. I mean, you take, 30 yards, turn the boat around. But if you're in a 50-foot boat, you cannot turn that boat around at 13 yards. I mean, you can't, it just doesn't have that radius. So that's what I think the healthcare system is like. It's like a, 3,000-foot boat, and we're going to try to turn it around. So it's going to take some effort. It's going to take a lot of calculating. It's going to take a lot of execution to make it turn around. Your discussion point on healthcare providers, whether they're physicians or nurses or psychologists in the system, or psychiatric nurses or psychiatrists, anyone who's in the system, or volunteers, however you reach someone who's trying to help you. I think the idea is we need to do a real good job of disseminating the work, and then we need to get it out. So in other words, what I'm going to try to do in the next little while, hopefully I get support for this, is we're going to start to take these types of things, these constructs, and put them into programs, test the programs, and then try to give them to places to do them. So I think it's about, planting seeds and growing those seeds. There are going to be I know some physicians who are very psychologically minded, who are very patient oriented, and are very involved in trying to get patients to resources. I know those guys, and I know those women, and I know other providers who just aren't quite there. It's just, again, it's about catch up. It's about education. It's about, preferences. So we have to try to kind of let everyone know first what we want to see happen. And then the understanding of these factors will come in. Another thing that patients can do is you can inform yourself, tool yourself in terms of these constructs and what you might be able to do. I think it's great that, we get support through our system, but depending on where you are, if you remember my slide about like there's green people, orangey people, and some red people, if you will, depending on where you are in that group, if you're suffering from some mild distress, just seeing a psychologist with no particular training in IBD will be beneficial for you. Like that will help you. Seeing a social worker could help you. Seeing somebody who has training in mood and training in sort of basic quality of life improvement is going to be helpful. Now, obviously, as you go higher up in distress, all the way up to like suicidal ideation, then we want to see experts come in and manage you at that point. So I think it's about understanding where you might be and what you can do for yourself, because many patients who come in at a moderate to mild level of discomfort, but still distressing, self-help books, talking with friends, engaging in exercise, watching what you eat for your diet, talking carefully to your GP and your GI doc if you're lucky enough to be engaged that way. All of those sorts of things are important. And sometimes support groups are important. It's another thing you can do for yourself that doesn't require anything. I know there's a lot of support through Crohn's and Colitis Canada, do a fabulous job, and there might be support groups in your area. And I can tell you, if you do something in those mild to moderate stages of feeling sad and upset and kind of confused, as long as you're trying to do something, it just helps with that sense of helplessness. It just can take a little bit of that away, a little bit of that edge. And it's so important because I find one of the things that patients do or they report doing is clamming up. Sorry, that's probably a maritime expression. I'm from Halifax, but clamming up or shutting down or kind of feeling like they can't bother somebody else. That's just so much not true. And I would say to you, if you feel like that, think of this. If your best friend was in the situation that you find yourself in, your best friend, what advice would you give that person? This is so important because you wouldn't tell them to clam up. You wouldn't tell them to go hide. You wouldn't tell them to kind of not try to talk to people. You would say, talk to me. You would give them advice that would be helpful. But we are so bad at giving that advice to ourselves. I get it. I understand that. But I think if you're in that situation, ask yourself, what would I tell my best friend to do? And then act on that action, and maybe that will be a little bit helpful. But I've talked a lot about options. I apologize if I've confused anybody, but there's so much you can try to do. But depending on the severity of it, if it is very severe, obviously, get some help at that level where your physician's going to be able to do that for you.
That's amazing. That's really valuable tips for people, especially, so that learned helplessness there's things that people can do. I think that's taking it and, them owning their own treatment.
And I just think it's so important to get out of the space that your head can be in and say, what would I do for my best friend? What would I do for them? Because you can answer that question. You people answer that pretty quickly. But
Right.
when I say, what can you do for yourself? They go, I don't know. So I think it's just a good exercise to get out of your headspace and then maybe take your best advice.
Absolutely. And I love your advice about like exercising and eating well, and just those tips to keep yourself healthy so you don't get to the point where you're at such a high distress level that you're, is there anything you could talk about? I know, we've talked about learned helplessness and all these, the things that go into it. Is there anything you could talk at all about suicide prevention with people with IBD?
Yeah, I think the first thing, there are standardized programs that could be adapted to, the larger picture here. And the first thing is, if anyone has those types of thoughts or feelings, or, find yourself in that situation, there are helplines, they're online. I don't have anything up here, but there are Canadian helplines that are really good. Like there's suicide hotlines, jack.org has a whole bunch of different types of things. I'll mention that in regards to support for suicidality, but there are emergency hotlines that you can call. And if you don't talk to somebody about it, that's going to be the largest burden. So, and sometimes, people are afraid to hear that you feel so bad that you have thoughts of hurting yourself. But I can tell you it's when, and people are afraid to ask you that. And you know what happens in most situations, like in a lot of situations, patients actually feel relieved to say that. Like, yes, I felt so bad that I felt like hurting myself. And they're usually quick to say, well, I'm not going to do it, but I have felt that way. I felt like I'm driving, there's a tree, I'm going to crash this car. I can't take it anymore. And these reactions are things that if you, it's almost like if you talk about it, you just unload it. And we get scared to ask patients about this, to ask people we love if that is something that's on their mind. And if you don't have that conversation, you've just not had that conversation. And that conversation could be so important. Because if someone says, yes, I feel like that, right? Then your next thing is, how can I help? And just be there with them, provide empathy. You don't need to provide a solution. If they go, I don't know, then the thing you do is you just say, okay, I'm going to sit here with you. I just want to be with you. You're not alone. And that can be, that's like medicine.
That's powerful.
That is powerful. Just that connection. When you're at your lowest, someone says that. And of course, you can talk to them, say, do you have a plan? Like, are there guns in the house? Like, if there's things that are put you at an immediate risk, then I think it's the person's responsibility with that person to say, let's get help. Like, I need to help you now. Like, this is not, we can't blow this off. Like, this is so important. Let's do something about it. Let me help you. Let me be with you. Let's do something about this. And in the worst case scenario, where someone does have this, plan and they look like they're ready to, you have to call somebody. You have to intervene. I think that's the mandate. Like, psychologists at some point, they tip the scale. And if the person doesn't want to go get help, they have to get help for the person. Now that is at the extreme level, but I just think it's important to understand there's levels of what you can do. But the first thing is just try to be there. And I want to destigmatize the word suicide in a sense, because I want people to understand that I know a lot of people in my life who have said to me, yeah, I've had those thoughts before. I had a thought about hurting myself when I think about it, but I never did it. I don't think I was serious about it, but that thought did come into my head. I was so distressed. And I think that's the other thing. When we talk about 40% of our patient sample, right? We're not saying that 40% are at that risk line where I got to call and we got to intervene and get in there and get them out. That's not the number, but that suicide risk has a band on it. And I think we need to reply to that band. And that's what I was getting at when I say I'm not happy about, that finding. I was like, wow, okay, so let's do something about it. So I want to understand it's a band of worry for me is, I think, a better way to describe that. I hope that answers your question.
Yeah, well, that was my question. I want to, one of the individuals who are participants who are watching is an IBD nurse in a clinic, and she said that some of these nurses do guide patients for resources for better mental health, and she wanted to know what your thoughts were about natural products to either help manage anxiety or slight depression, because she's seen people feeling hopelessness, but they turn to natural products, but they might not be safe at times. So she just wants to know about that.
Yeah.
IBD patients.
Yeah, I can make a general statement about complementary and alternative medicines, but I'm not going to, go out and say this is bad or this is not bad, because I don't study that, and I don't really want to start a wave. I can tell you that there are many natural medicines that people can use and will use that are helpful, and part of the discussion that you need to have with any type of medicine that you approach, whether it's considered natural or not, there's still substances. I think that should have that with your doc, 100%. And you might be surprised rather, how open some of the physicians are to some of the products that have some science behind them. So there's that. The other thing is too, I remember a patient once said, I'm going to take vitamin C because it is the sunshine vitamin. And they weren't taking a medical dose of it, but they said, every time I take that pill, and I said to them, if it's a sunshine vitamin, why don't you think every time you take that pill, it's going to make you happy? Because you're tired of not being happy. And they're like, well, it seems kind of, I said, come on, let's play a game. Let's just try it. Let's just do it. It's the sunshine pill. And you're going to take one sunshine pill every day. When do you want to take it? In the morning, when you get home, where do you want to be your sunniest? So this patient and I played around a bit like that. And then she said, okay, I'll try it when I get home, because sometimes when I come home from work, I'm pretty cranky. So I said, okay, fair. I'm cranky when I come home too. So she started taking this vitamin C, and she said, my sunshine pill, and took it. And then she said she actually felt happier. Now, we know that this is a placebo, so it's not really making her happy, but it gave her the opportunity to reflect on her desire to be happy and to reset her mind. So it's just a little trick. It's like, I'm going to take this little happy pill, bank, chew it down, exhale. Okay, I'm going to try to be happier now. And she went out, and you know what? She said she was taking the vitamin C. I saw her 6 months later, still taking my sunshine. And it's like, so again, I'm not saying complementary medicine is placebo, but what I'm saying is, for some people, some substances will work that aren't known as medicine. So just try some, you can try stuff, but be careful. And if anything looks medical grade, if you're taking dosages and you're talking about it as medicine, then I would definitely run it by your doc first. I think that's just the safest way to go, because there could be interactions with food. There could be interactions with, things you're not thinking of. So I would just, it's great if it works for Mary down the road, but I just wouldn't mean I would jump on that wagon immediately.
Right. Good. Well, that's great information. One last question for you, Dr. Tripp.
Sure.
How do you account for patient variability? So those who can and those who can't seem to find a way to feel empowered by their involvement with the disease. So how do you account for that?
That is a fantastic, I love that, because that is my favorite thing, because whenever I meet people, I talk about staging a lot. So you talk about variability, right? A great word. And when you look at people are not the same. So when I talk to you, Cindy, or I talk to Mary, or I talk to John, or I talk to Jackie, or I talk to anyone else, when I talk to people, it's about where you are, how ready you are. And I always talk about the life cycle of psychotherapy, because, you know, a lot of people come into something like psychotherapy, and you know, the average length in psychotherapy, I had a research project some time ago, I taught this to my students, the average length that patients would spend, and this is a broad number across a broad bunch of conditions, not just for IBD. The average length that people spend in psychotherapy is 1 session. Think about that. What are you going to get done in 1 session? Like nothing really, right? You know, you're going to meet somebody, you're going to not like it, and you're going to leave. That's basically what happens. But now that's an average, and it's skewed, and there's many people who go on to do more. But the people who go into that first session, I always say it's like a tryout. It's just a tryout. So you have to get a sense of where people are and how ready they are for moving into something like a psychotherapy, to committing to looking at themselves, to committing to asking those questions and analyzing their thinking. That scares the heck out of a lot of people. And a lot of people think it's like, you know, it's some kind of weird experience. I don't want to do it. And it's terrifying for them. And they don't have practice doing it. So depending on those types of responses from the person, I would adjust. I would say, okay, well, why don't we just hang out today? Why don't we just talk about, like, you know, baseball, fishing? What do you know that you're really good at that I don't know about? Tell me about, you know, playing blackjack. And you sit down and have a discussion. Because sometimes people just want to get to know you. They're not ready to come in the door and give you all this stuff that's terrifying them. So I think when you talk about variability in patients, it could be their pain, it could be their psychological readiness to engage in a therapy, it could be their cultural position, it could be an ethnic concern, like there are diversity issues. Like, you know, if you're a Black patient and I'm a white psychotherapist, is there going to be something we need to work on? Do I have to have more sensitivities? Like, you know, if you're Indigenous or not. I mean, there's a lot that we have to be mindful when we meet people, because it's not just about, you know, your disease. It's about you. It's about your culture. It's about where you are. And it's about your life experience. So it takes, in my opinion, it takes a kind hand and an authentic stance, a real stance to meet the person. And once you two can make a bond, then you can start to kind of look at working on things that you feel. And I'm a big believer in allowing the patient to tell me where to go. So I always say, let's pick 3 things you want to really knock out, and then we'll see what we can get done on them in this amount of time. So I think depending on that approach, we try to look at that variability and put people, like I was suggesting in that diagram at the beginning of my slides, into places that best fits them. And I would like the patient to come in and have that discussion with me or with others. I think that's an important thing for variability.
I think just to clarify, I think to expand on that one question, it's also about a question of how do you get somebody to kind of, because I know Jackie, who this symposium is in honor of, was very much into empowering people. So, you know, how does somebody go from feeling disempowered with their disease and that whole learned helplessness to suddenly feeling empowered, and I can live and I can move on and I could live with this and be successful in my life? Is there anything you can say, last words about that?
Last words is do something. And people feel empowered when they've done something. And it could be a discussion. It could be like, I know a young woman who all of a sudden said, you know what? I'm tired of this, and posted about her colostomy on Instagram. And she's got a bunch of followers. She met all kinds of new friends. She has, you know, a picture of her in the bathing suit. She's like, I'm out here now. And she said, I can't believe how this small act, and it was a huge act, actually, a brave act to do that, to beat back my shame. Those were her words. So I think if you do anything that moves you a step from feeling less empowered, you're moving in the right direction. And I can't prescribe one step in particular, but I can say, take a step, try, be brave, and see what it does for you.
Okay, Thank you so much, Dr. Tripp. I know there's a bunch of people who've said excellent information. They actually would like to be in touch with you and follow up with you. And I had another text from somebody that you could help one of their daughters. That is his contact information at Queen's University. I could supply that information to everybody as well at the end of the presentation. When I send the recording, I could supply the contact information of all the speakers, including Dr. Tripp. So I just, everybody has said amazing presentation, great solutions, positivity, and I just want to, everybody say thank you. So I want to say on behalf of Crohn's and Colitis Canada, thank you so much for your time. Thank you for the presentation. Thank you for the great information and tools, and wish you lots of continued success in your research, and look forward to putting it more into practice.
Yeah. Well, we will continue on. I have my wish list. We're going to keep plugging away. Thank you.
Yes, I hope you find your wish of your day. And thank you again for all your great information.
Thank you so much.
Okay, have a good rest of your day. Thank you.
I will. Bye-bye.
Bye. Sorry, everybody. We're just, we wanted to also thank BG Communications for their translation.
Thank you very much. Now I'm going to present Natasha Haskey, our next speaker. Thank you very much, Natasha, for taking the time to ensure that we present, that you present a really important topic, which is diet. So Natasha has been a practicing dietitian for 20 years and is currently pursuing a PhD under supervision of Dr. Deanna Gibson at the Center of Microbiome and Inflammatory Disease Research at the University of British Columbia. So her PhD focuses on how components of the diet, in particular fat, influence inflammation and the gut microbiome in IBD. And Natasha is actually also a co-author of Gut Microbiota, Interactive Effects on Nutrition and Health. So it's one of the first textbooks in Canada to provide a broad overview of gut microbiota and nutrition. So thank you very much, Natasha, and now the floor is yours.
Thank you. Okay, so
I just want to, sorry, Natasha. Hi, it's Cindy. I just want to let everybody know we see the French screen. So whoever's on their computer right now, you can go to View Options and drop down the list, and you go to Natasha Haskey's screen. So for some reason I think many of you might be seeing a French screen. So please go to View Options. There's a drop down and click Natasha Haskey if you'd like to view it in English. Thank you. Or send any questions in the chat and I'll help you. Thank you.
Okay, thank you. So I'd like to thank the organizing committee for actually having me today. It's always a pleasure for me to come as a dietitian and share my knowledge around IBD, but also as a scientist and sort of share some of the latest information when it comes to the gut microbiome and how it may impact inflammatory bowel disease. So I do have a couple disclaimers and they are listed here. And what I want to do today is focus around more of the research around diet and IBD. There's still a lot of work that needs to be done when it comes to how we can actually treat IBD with diet. But I really want to focus today on the state-of-the-art knowledge around what's happening with gut health, diet, and inflammatory bowel disease. So to begin, I do want to say that when it comes to our microbiome, it's influenced by a number of factors, and it's generally our microbiome, or the bacteria in our digestive tract, generally are formed within the 3 years of life, and that remains stable throughout life. And so over a great deal of research, I should say, we've discovered that there's a number of factors that do influence our microbiome, and it really begins from how we were actually born via C-section or vaginal birth, how we're fed in infancy, and then also where we live, medications we take, and then some of the daily activities that we participate in, including physical exercise, whether we smoke, our stress levels. And then one of what we've been finding in the last few years, or what seems to be consistent, is that actually diet and medications are some of the key factors that influence the microbiome. And when it comes to medications, one of the things we know most about is antibiotics and how they actually influence the microbiome, meaning obviously antibiotics are out there to kill some of those bad bacteria, I guess we could classify them as, and it actually can result in major shifts to the microbiome. So one of the things that I try to help people understand is that, okay, if diet actually influences this microbiome, how does this actually happen? Like, why does what we eat actually matter? And what the research is saying is that depending on what we eat, it can actually change those bacteria that live in our digestive tract. So it can have both positive and negative influences depending on what we eat. And what's interesting is that basically there's different stats, but 75 to 80% of our immune system actually lives in our digestive tract. So pretty powerful stuff when you think that if what we eat can actually impact our immune system. And what also happens is that if we are able to change those bacteria, some of those bacteria can actually produce different types of substances. And these substances are basically referred to as metabolites. So there can be good things that these bacteria produce. There could also be some negative things that those bacteria produce. And they can actually lead to a whole host of chronic diseases. And in all honesty, I'm not sure I can name a disease that has not been, I guess, associated with changes to the microbiome. And certainly inflammatory bowel disease, there's some really good evidence to suggest that there are alterations in the bacteria. The real problem that exists right now is that as scientists, we don't really know what a healthy microbiota looks like. It's actually a very complex issue. And I know that as patients and clinicians, we really hate to hear this, that we don't have enough understanding yet, but it's actually true. And I like to use this diagram here to try and explain what I'm talking about. So what they're saying now is that if we have 3 individuals in the same room, and if we were able to take their stool, and that's how we look at the bacteria in the microbiome in humans, if we were to actually take the stool, look at it and determine what bacteria actually live in there, we would find that there are some consistencies between individuals, but there are also a lot of differences. And so you can have 3 individuals in a room that have very similar bacteria, but they have some different ones that sort of stand out. And the analogy I like to use is that if we look at the jelly beans in this picture, which would represent different types of bacteria, you can see that in these pictures, there's common bacteria amongst the 3 individuals. So you can see the colors, like there's purples in all 3 groups, there's some pink jelly beans in all 3 groups. But if you look at subject B, they have some black ones. And maybe subject A has more of the blue jelly beans. And so what this is trying to portray is that, well, these 3 individuals are all actually quite healthy, yet there are some differences there. And the problem is that, okay, if all of these 3 people are healthy, how do we know which one is sort of, you could say, the healthiest? Or should we be changing everyone's microbiome to subject A or subject C? Because sometimes we don't always know those consequences. And this complicates the issue when we're talking about supplementing with different natural health products such as probiotics, for example. We need so many bacteria in our body, and how do we know, like, and there's trillions of them, how do we know if just one probiotic is going to work? So, as I mentioned, patients with inflammatory bowel disease are known to have alterations in the bacteria in the gut. And this is just, if we look at the pie charts, this is just a very, very high level overview. When they take patients with IBD, look at the stool and compare it to a healthy control, they can see that there are different types of bacteria. And the names listed on the bottom, those firmicutes and bacteroidetes, those are just names of different types of bacteria. So what we think we know is that we need lots of different kinds of bacteria, and we need not only types, but lots and lots and lots of different types, different bacteria. And the analogy I like to use is that if we look at this field of wildflowers, you can see that there's all different types of grasses and different types of flowers. And so we would think of that as being quite healthy, versus the picture in the bottom right-hand corner. This may be a situation where, unfortunately, we don't see a whole lot of different types of grasses and flowers and all those sorts of things in the gut. And this may be what we could say a diseased or unhealthy gut might look like. And unfortunately, you can see that the picture in the right hand, bottom right hand, there's actually nothing to even protect the soil. And this is much like our colon. Like, we need all these different types of bacteria, and we need mucus to actually protect that, our colon, and prevent it, the bacteria from stimulating the immune system. And why this is important, and why I'm telling you this, is because it's what we eat that helps those wildflowers grow. It's what we eat that helps keep that mucus that we need to keep our gut protected, healthy. So as part of my PhD, I undertook a literature review. So I looked at all the information that was out there on diet and inflammatory bowel disease, and tried to come up with what would be the best recommendations at this time we could give to patients. And that's the information I'm actually going to share with you today. So one of the things that we have no doubt about is that the Western diet, which is a diet that has lots of sugar, containing emulsifiers, is very high in animal protein, low in dietary fiber, actually has negative consequences on the bacteria in our body and all the different types of metabolites those bacteria actually produce. We do know that it's linked with chronic disease. The one thing I don't like about this picture is that they're always saying that a high-fat diet impacts or causes detrimental effects to our gut bacteria. And what we study in our lab here at UBC Okanagan is actually fat in itself. And we actually believe that it's more important we look at the type of fats we're consuming. So there's no denying that certain types of fat may actually make inflammation worse. However, it's not always necessarily large amounts of fat per se. So bottom line is that a Western diet is not something we want to consume. We do know that it has been not the cause necessarily of Crohn's and colitis, but has certainly been associated with the development of the disease. One thing that I find very, very interesting, and this research study is relatively new, was published in 2018, and it's relatively scary in my mind, because what they reported is that in Canada, and of course it's an obesity study, but I think it has important implications. What it's suggesting is that half the calories we're eating as Canadians are coming from ultra-processed foods. Now, ultra-processed foods are those foods that come in a box. They have no fiber. They have some of these fats that we think are detrimental. So I'm not saying all ultra-processed foods are bad, but think of the canned soups and packaged and processed foods we can buy in the store. We do know the sodium content, the sugar content, the fat content are linked with detrimental changes to the microbiome. And yet as Canadians, we're eating half of our diet of these foods. The other thing I like to mention is that in a lot of these packaged processed foods comes a lot of emulsifiers. And emulsifiers are basically different types of food ingredients that are added to different foods that actually stabilize them. So if we think of foods that if we didn't put those emulsifiers in and they were on the shelf, they wouldn't be stable, or they would become liquid. So there's a couple of ones that are particularly concerning, and one is called carboxymethylcellulose. And they're often the big words that are sort of the last 3 or 4 ingredients you'll see on a food product. The information is relatively early when it comes to emulsifiers, but so far it's been quite negative. And as a dietitian, I feel that we don't necessarily need to be eating some of these packaged processed foods. If we go back to whole cooking, cooking from scratch, when there's time, batch cooking, we can get rid of some of those emulsifiers in our diet. And of course, be able to improve those the microbes. So as I was mentioning, you know, this diet, this Western diet that I was talking about, why it's so concerning is that if you look at this cartoon here, the picture on the left is what we would say is a healthy colon. So those black rectangles are basically cells that exist in our colon. That pink layer on top is that mucus. Mucus is one of the first defenses in our immune system and is extremely protective. We need to keep that really, really thick and healthy. And then those shapes on top are really the bacteria. So you can see there's a clear separation between the bacteria, and actually in that green areas where our nutrients would be, we need that clear separation from the mucus. But if we look at the picture on the right-hand side, for example, the mucus has been degraded. The bacteria are actually sitting on the immune cells, and unfortunately that would stimulate an immune response. So what we're finding is that if we have a diet that's really low in fiber, we get the situation that's happening on the right-hand side. These bacteria love to break down this mucus, whereas if we can have some dietary fibers, the bacteria can feed off of those fibers and end up not chewing down the mucus in the lining of our digestive tract. So we know another key thing that's pretty clear in the literature is that we do need to incorporate more fermentable fibers into our diet to feed those bacteria. So just to give you an overview, we do know it's such a simple message, but sometimes almost too simple. But what we're seeing from the science is that if we consume different types of fatty fish, which are rich in those omega-3 fatty acids, which we've heard about, the fresh vegetables, fruits, berries, we know that they've been associated with reduced inflammation. And when it comes to any type of chronic disease, including inflammatory bowel disease, the goal is to reduce inflammation. So what I find pretty cool as a dietitian, that like some medications might take weeks and months to kick in, there's some good science to say that we can change those microbes in our gut within 3 days. So we can get some really rapid responses when it comes to what we eat and how we alter the microbiome. And I mean, as IBD patients, I'm pretty sure you understand this can happen both ways. A lot of due to the intolerances, sometimes, you get pretty immediate results. But on a positive note, eating a healthy diet, we can change those microbes really quickly. So as I had mentioned, one of the things I'm really going to emphasize is fiber. And because it results in such beneficial effects to the bacteria in our gut and our body as a whole. So one term that we're starting to use, and perhaps we're going to hear more about, is something we call microbiota accessible carbohydrates. And the reason we're using this is because the world can't, I guess, agree upon a definition for what a dietary fiber is. So what's unique about this definition, and I'll refer to them, we'll just call them MACs because that's much simpler right now. But these MACs are unique in that they're the only ones that the gut bacteria can break down. Because there are some types of fiber, for example, that our bacteria actually do not break down. They just sort of travel through our digestive tract, make our stool bulkier, can help with constipation. And those are the things like anything from the bran family, cellulose family. So wheat bran, things like that. They actually don't stimulate the bacteria, but certainly would help bulk your stool and help what we call transit time or help with constipation. But there's a whole host of these MACs that actually can be helpful. And yes, they're often long names like fructooligosaccharides, galactooligosaccharides, inulin, resistant starch. A lot of times you're going to see them added into foods and they're going to be listed as prebiotics. Prebiotics being the type of fibers that actually feed the gut bacteria. And then beta glucan, which come from things like oats, pectin, which is found in all types of fruits and vegetables. And then the reason I have a question mark besides psyllium, which is often found in the Metamucil, is that there are some studies saying it's fermented by the bacteria, but there's also some that say it's not. So psyllium tends to be more of another one of those items that actually bulks the stool. So what we do know is that we need a variety of different types of fiber sources because different bacteria in our gut break down different types of fiber and then ultimately produce different types of healthy substances. So as I mentioned, one of the things I think we can do is incorporate more prebiotics in our diet. So this is just a scientific definition, and it's basically saying that not all fiber are prebiotics. So we can't say that, for example, wheat bran is a prebiotic because the bacteria actually don't break it down. But something like inulin, which actually is derived from chicory root, is considered a prebiotic. And there's lots of evidence in the science to say it can be helpful. And there's some good studies, in fact, in inflammatory bowel disease. So where does inulin come from? Well, inulin generally would come from bananas, artichoke, asparagus, garlic, onions. And then what's really, really interesting is that human milk is rich with also different types of prebiotics called human milk oligosaccharides. And I just like to mention that just because there's lots of information out there around children, and they're adding all different types of prebiotics into different types of formulas, for example. And what's interesting is that they're adding one source, yet we know that human milk has hundreds and hundreds of different types of prebiotics in it. And in fact, sometimes we don't even, actually science doesn't even have a handle on all these different types of prebiotics in it. So it's actually I find it quite fascinating. So one of the problems with prebiotics is that sometimes the amount we need to add into our diet can sometimes be challenging. So the chart I'm showing on the right is actually showing you how many different bananas, for example, you'd have to consume to get 5 grams of prebiotics. So one of the things that individuals can try is adding supplements into their diet. And I'm not a big proponent of supplements. However, when it comes to prebiotics, we get them from the diet, add lots of fruits and vegetables, but we can certainly try some supplements. When I say trying a supplement that contains inulin, I always suggest to people to start extremely slowly, even with half a teaspoon into their diet, see how their gut actually tolerates it, and then increase it over time. And our goal would be a tablespoon a day. So for example, the product in the marketplace that is most well known for having inulin is Benefiber, but each drugstore tends to have their own drugstore brand, it's much cheaper, and you just have to turn the label over and make sure that it does in fact contain something like inulin. So it's something to consider if you're trying to get more fiber into your diet. And so, as I mentioned, the rationale for this is that these prebiotics help the good bacteria actually grow in our gut. They stimulate something called short chain fatty acids, which is one of those metabolites or healthy substances that are produced by the bacteria. And what we know is that individuals that do have inflammatory bowel disease do not have enough short chain fatty acid production. And so we need those, I guess, metabolites to help heal a gut, because this is what actually feeds our intestinal cells. It's the primary fuel source. Our other cells in our body need carbohydrate, but our colon cells actually need these short chain fatty acids. Another really interesting type of fiber, and it's such a simple source, yet we know that we're not consuming enough, it's called resistant starch. And so how it's actually different than, say, starchy foods that we normally consume in bread or pasta and things like that, is that this resistant starch is been slightly modified, and it's just a natural process that happens, say, when we cook pasta and cool it, that our digestive enzymes can't break it down. So it actually just goes through our digestive tract, hits our colon, and then it is fermented by the bacteria. And there's some really, really interesting studies showing that it can actually increase certain types of bacteria, but it's also really, really important to our metabolism. So it's actually showing it can be helpful in increasing our insulin sensitivity, can also enhance growth of certain bacteria, as well as it's also been shown to lower blood glucose levels. So quite astounding effects on the body that go beyond the colon. And so where we find these types of foods is in things like white rice, brown rice, and breakfast cereals. So for example, when I mentioned ultra processed foods, there are some that, you know, are relatively unique. You think of cornflakes, yes, it's a processed food, but the way they manipulate the starch in this particular product makes it have some resistant starch in it. The other place you're going to find some of these resistant starch type foods are things like your beans, peas, and lentils. And I know that as a dietitian, you're saying, well, Natasha, I can't tolerate these types of foods. Yes, I've heard it from clients, but generally, if we think of some of the canned products, the canned lentils, peas, chickpeas, they've been sitting in the liquid for a long period of time. So if you can take those canned legumes, rinse them off really, really well under water, and then that gets rid of the compounds that actually cause a lot of the gas. And a key thing about the legumes is the volume. I'm not saying go out tonight and start having a cup of legumes, because you're not going to feel well, but you can have relatively small amounts, like say, for example, have even 2 to 3 tablespoons sprinkled on a salad, and people tend to tolerate that much, much better. So what they're saying is that why this is important is that they estimate that as Canadians, we're consuming 5 grams a day. And it's actually, a recent study just came out this year, and it was in the United States, however, and they were saying it's even lower than 3 to 4 grams a day. And what we need at a minimum is 5 grams per meal. So we're way, way off when it comes to resistant starch and actually what we need. I do want to mention protein, and I'm not saying protein is bad or animal protein in general, but when it comes to the science, what we do know is that large amounts of animal protein, in particular red meat, especially when it comes to inflammatory bowel disease, has been associated with changes to the gut microbiome and has been associated with IBD. And that, again, when I was talking about those healthy substances metabolites, they actually have been linked to IBD. So what I suggest as a dietitian, and I'm working towards with my clients, is that yes, you can still incorporate meat into your diet, and I'm not saying go vegetarian or vegan, but reduce it to red meat 1 to 2 times per, try and aim for once a week. If you're someone that's eating it every day right now, obviously try and reduce slowly. But we do see that a plant-based diet has been beneficial for the bacteria in our gut. And what we do know now is some of that protein actually does get to our colon, which is maybe wasn't known before. We thought it was all digested and absorbed in our small intestine. So if you're not someone that has been eating a lot of plant-based foods, even incorporating 1 plant-based meal per week can help, will help put you on the right track. And there's lots of different resources out there and dietitians that specialize in plant-based nutrition and have some amazing recipes out there for you to try. I also like to mention fermented foods because I think it's such a hot thing right now and sort of one of those things that everyone's talking about. So fermented foods come in a variety of different, from a variety of different sources. Probably some of the fermented foods we're most familiar with are the yogurts, the kombucha, sauerkraut, but also miso, kimchi, tempeh are some other examples. And so what I like to always emphasize is that when it comes to fermented foods, they actually, most are not considered to have probiotics in them, because to be a probiotic, it has to meet some very specific scientific criteria. But fermented foods have live active cultures. So we have so much more research to do when it comes to figuring out what bacteria are actually good in the types of fermented foods that we're buying and purchasing from stores, what we're making in our homes. But there are some real interesting health benefits that go beyond the live active culture that have been found in fermented foods. Like, we know that fermented foods can enhance the protein quality of the product. It enhances our body's ability to use the vitamins and minerals. It has antioxidants in it. And again, it produces some of those good compounds that are needed to produce anti-inflammatory activities, which ultimately impact our immune system and help with control of things like blood glucose levels. So in my opinion, even though we don't know which, say, bacteria are beneficial, say, in some of the live active or the fermented foods out there, they certainly can be helpful to incorporate into your diet because they have been linked to a variety of health benefits. So now I just want to take the last little bit of this presentation to talk about fat, because it's sort of where my focus has been in my PhD, and it's relatively novel because there's not a lot of science out there when it comes to dietary fat and how it impacts the microbiome. But yet I feel it's very important to any patient that has inflammation, but in particular inflammatory bowel disease, because that's what I'm studying. So what's interesting is that really when it comes to fat, we've really had, there's been a negative connotation when it comes to fat. It's really been portrayed as evil. And we've heard things like dairy is bad because of the saturated fats in it. We're hearing that, there's been this switch for a number of years to reduce our fat intake, and which ultimately the food industry followed and sort of cut out a lot of the fat in our diet, and we went to low fat, fat free. And then we're also now seeing a shift into people consuming the ketogenic diet and eating more fat and going on low carb diets. So even as a clinician, it's extremely confusing. Should we be consuming more fat? Should we be reducing fat? So I want to share some of my research today. One of the things that's come out this year, new research, and it's saying that we have, unfortunately, we have the dietary fat guidelines when it comes to saturated fat all wrong. Some of the studies that were done when we started recommending cutting out saturated fats from our diet were extremely flawed. And now it's come to light that, in fact, we do need some of those saturated fats. And so I'm going to talk a little bit more about some of these recommendations. And so this is another really important study that came out this year saying that we need to change some of our recommendations around fat. So why do we even need fat? Like, why can't we just cut it from our diet? And the reason is that lipids, which are sort of the umbrella term we use, dietary fats are just one component of lipids, but we need lipids because they are important in our cell membranes. So basically, they keep our cells healthy. Lipids also send signals between cells. So we need signal. There's this complex signaling that goes on in our body and tells our body like how it's supposed to function. If these chemical messengers change, then we see the development of chronic diseases. It's an important source of energy. We need it for all of our hormones. And what's also important, I love to show this picture of a cheesecake with a full fat latte, for example. Fat is also very important in making us feel full. And so it actually sends a lot of satiety signals and pleasure signals to our brain. So I just want to mention that saturated fats come in a variety of different forms. They are generally, there's milk fat, which is a form of saturated fat. Coconut oil is another source. But then you see that food tray of processed foods. You can see that's a different type of saturated fat, and probably not the one that's definitely not the one I'm recommending today. But there are some actual healthy sources of saturated fat, as you can see in the coconut oil and milk fat. Now, there's also different types of oils. So the MUFA, or monounsaturated fatty acids, are the olive oils, avocado oils. There's omega-6 fats, which found in corn oil, safflower, and sunflower oil. And then, of course, the healthy fats found in things like the fattier fish and flaxseed, and generally associated with beneficial health effects. So what's unique is that all these different types of fats can actually affect inflammation in different ways. So to say a high-fat diet is bad is a little bit of a misnomer, because it really depends on the type of fat we're eating. So it's confusing. Is fat good? Is it bad? And hopefully I'll shed some light on that for you right now. One of the challenges right now is that when it comes to our Canadian guidelines, there are actually no recommendations when it comes to how much saturated fat we should be consuming, how much monounsaturated fat. All it's saying right now is that we should just cut out saturated fat and replace it with oils. But my argument is that the oils we're eating can actually impact inflammation. And we've seen that in our lab. These are very high-level studies that have looked at different types of fats and what they've done, what they do to the bacteria in our gut and how they impact inflammation. So our lab has concluded, or the work I'm doing in our PhD, is that type of fat does matter, and we can influence our microbiome and inflammatory responses by looking at the type of fat we're consuming. So basically what our lab has concluded right now is that those omega-6 fatty acids, such as corn oil, canola oil, sunflower oil, actually we've shown in a variety of different animal models can actually stimulate damaging immune responses. Olive oil seems to be protective and can be a beneficial fat. Milk fat can be damaging, but yet it's very, very unique in that it actually has some properties in it that actually help stop inflammation. And then what we find is that fish oil needs a little bit of saturated fat in order to be beneficial. So some of the research out there has suggested that we should go out, take omega-3 supplements. But what really concerns us is that if you don't change some of the other fats in your diet, it can actually be quite detrimental. So this led me to actually my research, and this is when I joined UBC Okanagan. And the reason I did that is because as a dietitian, I was really frustrated with what we knew around diet, and I really wanted more answers. So my PhD actually focuses on a clinical trial as well as an animal study looking at, what if we changed the type of fat we're consuming? Would this have an impact on inflammatory bowel disease? And I'd like to say, even though I'm still in the midst of my clinical trial, we're actually seeing some very promising results. And the diet we're actually using is the Mediterranean diet. And the reason I chose that diet is because it sort of matches what we found in our animal models when it comes to looking at colitis. Obviously, we have to use animal models as well as human studies to get to the bottom of this. Our animal models, we can't go and give humans just a diet rich in corn oil or omega-6 because it's not ethically feasible. And obviously that a human can't consume a diet like that. It would be virtually impossible. But what we're seeing now in our clinical trials is that, in fact, we've seen that the disease activity does drop. The results aren't significant, but I need more of a sample. But we see that there has been improvements in disease activity. We also see some improvements in quality of life, meaning people that were on the diet indicated that they felt better. And in fact, some of the patients at the end of my study wanted to continue with the diet after they were finished, simply because they were feeling better. And the last piece, as a dietitian, there's no point in trying a diet in a patient population if, for example, they get more symptoms, feel sicker, can't actually follow the diet. And we're actually seeing patients being able to follow this diet. And what I find particularly cool is that the substance that's most beneficial for the colon cells, it's called butyrate, actually went up in the patients that have that were following our Mediterranean diet, with the exception of that one individual. And I haven't figured out why. Maybe they weren't compliant, but the rest of the individuals in general were producing more butyrate by consuming the Mediterranean diet. Whereas those that, when I say habitual, I also have a group that just doesn't do any changes to their diet. They fill out my questionnaires. Unfortunately, we saw no changes. And in fact, we saw a drop in that butyrate. So showing that if we can change the diet, we can quickly make changes to the microbiome and improve the health of the gut. So with that said, my bottom line is that I think we need to change the way we think about fats. We need to include sources of healthy fats in our diet, but in particular, get rid of those omega-6. And so again, I hear the people say, well, I don't use corn oil, safflower, sunflower oil. Well, unfortunately, all of our ultra processed packaged foods, a lot of our meats that we consume are very, very high in omega-6. And there's lots of hidden sources. And in fact, in Canada, if we look at a package and it says vegetable oil, and it's not specified as to what type, in general, it's going to be that omega-6. And another thing is soybean oil is rich in omega-6, and that's in a lot of food products. Secondly, is that we need to get omega-3 fatty acids, and we encourage them from different types of fatty fish. And I've listed the type of fish you can get it from. Not all fish contain omega-3 or high amounts of omega-3. We need to change the way we think about meat. So thinking like maybe red meat once every 2 weeks, white meat being chicken, turkey, twice a week, and then the rest trying to go plant-based. Including dairy. Dairy can be beneficial, as I mentioned, for inflammation because it has this ability to stop chronic inflammation, whereas some of those omega-6 fats, like the corn oil, safflower, what's detrimental about them is that they promote the inflammation. They have no way of stopping it. Vegetables, it's because of the antioxidants. There's something called polyphenols, and fiber in vegetables all feed the microbes. Even aiming for a vegetarian meal once a week, and then incorporating different types of grains. And by cooking and cooling some of these grains, they can be used in different types of salads and things like that. By cooking and cooling, I should say, they create this resistant starch, which has been shown to be beneficial in the diet. And finally, one of the things, just a tip that I can give is that every meal and snack should include something that feeds those microbiota. So trying to think about fiber in every single meal. And with that, I am still doing recruitment for my colitis study. This is posted on the Crohn's and Colitis website. I'm looking for patients that are 18 years of age with colitis, taking Humira, Remicade, that don't have previous surgeries, willing to follow the diet or change your diet and provide stool samples and blood work. So my contact information will be at the end of this, and please feel free to contact me, and I'd love to have you, and you can be anywhere in Canada. And with that, I will certainly take some questions.
Okay, fantastic. Thank you so much, Natasha, for that amazing informative presentation. I know a lot of people probably have gotten tons of information. I definitely have a few questions for you. First of all, what dietary differences do you suggest for someone whose disease is currently active as opposed to someone who's in remission?
Right. So when you're active, the diet is going to be different, and you don't want to be playing around with high amounts of dietary fiber by any means, but you also don't want to be avoiding dietary fiber for long periods of time. So one of the things that I think as new dietitians, we've kind of always recommended this low residue diet. And in fact, I think we should probably be distinguishing between fibers that, like the insoluble fibers. So during a flare, it's not a good time to be adding the wheat bran, the foods that have a lot of residue, for example, found in like raw fruits and veggies. So if you're trying to, you still need those fruits and veggies. And what I could recommend or would recommend is investing in a really, really, really good blender. because a blender will pulverize all those, you know, nuts and seeds and fibers that are found in the fruits and vegetables, or cooking fruits and vegetables so that they're softer. We still need to incorporate those foods. Another thing that I would recommend is maybe incorporating some of those soluble fibers, because we should, if we don't feed the bacteria, like they're not going to get better. So things like some of those soluble fibers, things like the resistant starch, for example, is not going to cause generally a lot of symptoms. So even things like your rice, pasta, things like that, cooked and cooled, can increase the resistant starch. Things like oatmeal, that's a way to get a little bit of fiber into your diet without completely cutting it out, because we do need some of those foods to heal the gut.
Mm-hmm. Another few questions on what's the best way to consume vitamin D so it'd be well absorbed by an irritable gut?
Right. So we don't get enough vitamin D from food sources, so it does have to be consumed through a supplement. And so generally, a lot of gastroenterologists will check your vitamin D level once per year. And it's one of the, vitamin D certainly is one of those nutrients that has an important role in the immune system. So generally, most people will be able to absorb it. They might just need larger amounts. And so generally, the Canadian recommendation is 1,000. So if patients with inflammatory bowel disease go get their levels checked and find that they actually are lower, they're probably going to need much, much more than that. And in fact, if your gastroenterologist is following you, a family doctor, or even a dietitian, as an individual, you may need larger amounts for a shorter period of time. And a lot of times vitamin D doesn't increase overnight. It takes about 3 months. So if they do a test and find that like normal levels are around 80, if you're around 50, you not only need that 1,000, but to get it up to 80, you need another 1,000 units. So some individual might need a 5,000 international units. And that really should be monitored by a health professional. And in some cases, individuals that vitamin D levels are so low, they may need massive doses, and those would come through prescription. So it's something I really feel you should work with a health professional. But generally, it's not necessarily a problem of absorption more than needing more to get those levels up.
Okay, thank you. Another question, quick question. What about taking pre-probiotic supplements? What's the recommendation as for timing, before, during, or after meals? And what about Metamucil or flaxseed type products?
Okay, so the probiotic issue is really controversial right now. In Crohn's disease, I really don't recommend it. Some of the studies have been very, very negative, and the reason for it is that we know that probiotics stimulate the immune system, and I don't think we found the probiotic that we need for Crohn's, and even for colitis. The more we know, sort of the less we know. So we don't have, the probiotic would be generally can sometimes help with the symptoms. So as far as when to take a probiotic, not saying I necessarily recommend one, because again, if we go back to not really knowing what they're doing right now, it doesn't really matter. There's no specific recommendations as far as timing when it comes to a probiotic. When it comes to prebiotics, again, doesn't matter because it'll go through the digestive tract. Metamucil, it depends. Some people, it helps them with thickening of their stool. So certainly give it a chance. Flaxseed is a great source of omega-3, although it's not as efficient and used as readily as, say, some of the fattier fish sources. But again, with flaxseed, it should be ground to actually help with absorption.
Okay, one last question with respect to time. How can you tell if a change in diet is helping if you're also on medications such as Humira, Remicade, etc.? So how can you tell whether it's the diet or the medication? Is there a way to tell?
Well, that's what we're trying to sort out as far as in our research. We are realistic, and as a dietitian, I'm realistic in that I don't think the diet diet is not quite powerful enough right now to get people completely off medications. We're going to need it as a complementary therapy. But I think in time, as we understand more about the anti-inflammatory effects of diet, there may be opportunity to prevent increases in dosage, for example. Some people may be able to lower their dosage, and obviously this would be in collaboration with the team. So.
Fantastic. I just want to respect everybody's time and your time so we can stay on time. Thank you so much.
Yes.
I think you've answered most everybody's questions. She did provide her contact information. You provided it already, and then I could send it again. Here you go, natasha.haskey@ubc.ca. So there's a way to have further questions about the presentation. And again, if you can just move to the next slide, Natasha. I just wanted to thank again BG Communications for doing the translation free of charge for all these amazing presentations by our speakers today. Thank you so much, Natasha. You were wonderful. Your information was amazing and so in-depth, and I know people are going to have a lot to think about, and you gave them a lot of good advice, and I wish you good luck on your continued research, continued success with your towards your PhD. And thank you again for your time being involved in this special event today. So thank you so much. Thank you. Everybody saying that it was a great presentation. So thank you so much, and have a wonderful rest of your day.
Thank you.
And for everybody else, we are going to have, one moment, please. Does everybody see my screen?
Yes, we do, Cindy.
Okay, sorry. You see my screen? Okay, perfect. So, oh, that was not meant to, that was supposed to be a previous screen. One moment, please. Sorry, everybody. Okay, so right now we're going to have a wonderful little break from 12 to 1, and we are offering you from Lynn Watchman a half-an-hour yoga stretch. So thank you, Lynn, for offering to do this so generously with your time. Lynn was a registered nurse for 25 years and has a 10 years experience in Ayurveda practice and Eastern medicine. And her website is www.lynnwatchman.com. I also want to let me know that she offers free meditation daily at 10 o'clock as well, 10 o'clock in the morning and 5 o'clock in the afternoon, as well as free yoga classes during the week through Dana, D-A-N-N-A. But you could find all her information on her website. And sorry, I meant to go. So Lynn, would you, and also she'd like anybody who, the yoga practice is going to be for the next half hour. And then you have a half-hour break till the next session at 1 o'clock. So Lynn has asked anybody who would like to take part in the yoga to please show their videos, because she'd like to see everybody who's doing the exercises with her. So if you'd like to participate, you're welcome to turn on your video camera now. And Lynn, you will begin showing your, I will stop sharing my screen, everybody, and I will have Lynn, are you on here? Sorry, hi Lynn.
Hi.
Lynn will be sharing her screen, and you'll be able to follow her practice. Okay. So anybody who'd like to watch, please take your camera off, and she'd love to see you. and love to see you do the exercise with her. And you will all be doing this for the next half hour. So enjoy your practice session and release some stress and get your body moving a little bit. And you know that's healthy for everybody also who has IBD and for everybody. So enjoy your practice. And after that, at 12:30 to 1, you'll have a break. And then this afternoon, we will be having from 1 to 2, Dr. Zwingerman, who will talk about IBD and fertility, followed at 2 o'clock by Dr. Dirks, who will talk about the transition from pediatric to adult care with people with IBD. So that's our afternoon schedule. So enjoy your yoga practice, everybody.
Rena, okay. Well, welcome everybody. First of all, I want to honor all of you for attending today's symposium. It was a real honor to know Jackie and her parents, Larry and Rena. And this is something that Jackie always honored, and that was education. So I'm so happy that in her memory, this can continue. All right, let's begin. On va commencer maintenant. La pratique est vraiment basée pour vous aider à avoir plus de relaxation, mais en même temps pour essayer de bouger les énergies dans votre corps et de gagner votre force. So we will begin now. Place your hands over your chest, and if anything hurts, don't do it. Find a way, or just pause and stand in Tadasana until you get to the next posture. We'll begin now. Inhale, letting the breath continue to breathe in until you reach the top. Exhale, the flow of breath all the way down to the bottom. J'inspire. J'expire. And with this, the next one, bend the knees just a little. Bend the knees, j'inspire, je monte. J'expire, je descends. Inhale. Exhale. One more time. Inhale. Exhale. Now, interlace your fingers. Place them above your head. Si vos épaules, si ça fait mal, I'm going to enlarge the screen. If it hurts you to lift, if your shoulders hurt, just place your hands at your sides or in this type of a position. We'll begin now. Inhale, come up on your toes. Exhale, come down. J'inspire, je monte. J'expire, je descends. We'll do this for 8 more times. Inhale. Inhale through the nose, exhale through the mouth. Or inhale through the nose, exhale through the nose. Encore. You're stretching your upper spine. And come up as high on your toes as possible. And it doesn't matter if you shake or if your balance isn't good. Try not to take yourself too seriously. Next posture, separate the legs about the distance of your hips. Okay, inhale. And what I want you to do is hold on to your arm and oops, I don't know if there's been an interruption. The screen has been, I hope you can all still see me. Inhale. I'll show you my arms. pull your arm to the side so you're feeling the stretch in the ribs, and come up. Now, you're not stretching from the wrist, from the waist, so don't go down too far. I see some of you are going down way too far. I just want you to feel this. Okay? I want you to do an effort of 6 on 10. Moins, c'est plus. Donc, we'll begin now. Inhale, exhale, go to the left. Inhale, come up. Exhale to the left. Inhale, come up. Exhale. The breathing is as important, if not more important, than the actual exercise. Last time, j'inspire, je tire. Je monte. Je descends. J'inspire, je monte. J'expire, je descends. And come into a standing position. You just now stretched your mid-back. Now we're going to work on the lower back. This is a little bit fun, just swinging from side to side. Okay, inhale, exhale to the back. J'inspire, j'expire, j'inspire, j'expire. And now just do it like a kid. Be fluid. Doesn't matter. Okay, good. Now everyone's on mute except for me. In order to get things moving, we also have emotions. Okay, so I want you to inhale, and I want you to reach into your body to a part that wants to talk. Ok? Quand vous inspirez, cherchez dans votre corps l'endroit qui veut parler, et avec l'expiration, parle avec un son. So it will look like this. Inhale. Exhale. J'inspire. Nobody can hear you. Exhale. Oh, except I can hear me. Oh. I'm hearing it here. And when I'm connecting, I'm feeling this part and I'm letting it talk. One more time. Inhale. Connect. Exhale. Asana. Feet the distance of your hips. Your arms at your side. Good. Squeeze the buttocks. Separate the belly button from your chest. So if you're leaning over, come up so you have a nice straight back. Shoulders come down. How? Comment? Let the shoulder blades, bring your awareness to them. Let them come down. Just by your intention. Imagine now that you have something on your head, even your hand, and push against it. Let your chin drop slightly and push against your hand. Poussez contre la paume de la main. Pour sentir l'étirement de la nuque. Good. Now roll the shoulders back. This is called Tadasana. C'est pas une posture de lâcher prise. This is not a letting go posture. That's why it looks like the army posture. Okay? This is lâcher prise. This is neutral. Okay, on va continuer. We're going to do balance. I want you to focus on a spot on the ground and follow. I'm going to show you first. I'm going to inhale and come up onto my toes. We'll begin now. And we will hold the posture for the count of 10. J'inspire, and I'm pulling up. Pull up on your thighs. Squeeze your buttocks. Pull up here. Let the shoulder blades drop. Imagine you're holding a ball. Come up higher on the toes, and exhale, come down. Inhale, come up. Exhale, come down. Inhale, come up. Exhale, come down. On va le faire une autre fois. Inhale, squeeze the buttocks. Bien plaquer la jambe au sol. OK? Les deux, plaquez-les. Allez sur les orteils. Montez, 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 montez. You can lift up your arms or put them at the sides. Hold it. 1, 2. Look down at a spot. Regardez un point sur le plancher. Ça ne fait rien si vous bougez. Essayez de vous équilibrer. Montez, montez, même plus haut. And come down. Good. Inhale, come up. Exhale, come down. Inhale, come up. Exhale, come down. Next posture. The tree. Can you all hear me? If you can hear me, give me a thumbs up. Okay. The tree posture goes as following. My hips, find your hips, put your hands on there. They should be facing forward. Vos hanches, ils vont faire face vers l'avant. Okay? And this is a balancing posture once again. So bien plaquer votre jambe au sol, really push your leg into the mat. Now, this leg is going to be pointing outward, but not my hips. Always hips forward, then wherever the knee can go. The next way to do this posture is between the knee and the ankle, entre le genou puis le talon, ou bien plus difficile, okay, is going to be right up near the groin. On va commencer maintenant. Tadasana encore, on revient toujours là. Pull up the thighs, pull the muscles, squeeze the buttocks, separate the belly button from the chest, roll the shoulders back, push against that imaginary hand or a real one on your head. Now you're ready. Lift up the right foot and hold the posture. Keep squeezing. I want you to use the outside of your foot to push in. I'm not using this part. I'm using the outside of my foot. That's what it's pushing against my leg. Keep holding it. You can lift up your arms. You can come into this position, to the sides. C'est comme vous voulez. And come down. Other side. Once again, Tadasana. Pull on the thigh. Squeeze the buttocks. Separate. Shoulders back. Head up. And begin now. Hips vers l'avant. That's franglais. So why am I doing this pose with you? What does it have to do? What does it have to do with, yoga for Crohn's and colitis, irritable bowel, inflammatory bowel disease? Well, when we balance, quand on équilibre, ce qui se passe, c'est qu'on calme notre système nerveux central. When we do balance in yoga, it calms the nervous system. Other side. So it doesn't matter if I'm jiggly. What I'm trying to do is I'm trying to calm my nervous system by balancing. And it works. Squeeze the buttocks. Excellent. And come down. Other side. And look, I've got a chair here. If I need help, I'll lean over and I'll hold on. Last time, hips vers l'avant. I'm pushing on the outer part of my foot. My knees coming out. I'm looking down. Je vous montre comment le faire, comme ça tu peux le faire chez vous. Explaining it so you can do it at home yourself. Excellent, come down. Inhale, come up. Exhale, come down. Inspirez une autre fois. Now, cardio time. Easy way to get cardio is squats. Give me a thumbs up if it's going okay for everyone. Okay, super. All right, so this is what it looks like. I've got my feet separated the distance of my hips, and most of the weight is going to be on my heels. Lift up your toes and now put them down. This is what I'm going to do. I'm going to imagine I'm about to sit down. I'm pushing my buttocks out, and then I come up. So I'm not going this way, I'm going back. If you want more effort, si vous voulez avoir plus d'effort, place your hands in front like this. And I'm looking at the floor. Okay, we'll begin now. We'll do 12 reps. Inspirez, montez à l'expiration. 2, 3. For a 30-minute class, this helps with your cardio. Press on your heels when you come down. Most of the weight should be there and in the thigh. Nothing, almost only 20% should be forward. All right, 6, doing well. No pressure should be on the knees. If it's too hard or you're feeling pressure, hold on to the back of your chair and come up like this. Okay, continue. 3 more. 1, 2. J'inspire, je monte. J'expire, je descends. J'inspire, je monte. J'expire, je descends. And come up. And we're going to go down one more time and hold it for 10 seconds. If it's too hard, just stand in Tadasana. We'll begin now. J'inspire, je monte. Et je regarde vers le sol. 1, 2, 3, 4. Plaquez les talons au sol. Breathe into your upper chest, not your abdomen. It's too hard and too low. 9, 10. Squeeze the buttocks, squeeze the thigh, come up. Excellent. Come down and up and down and up. Has anyone noticed that they're breathing more heavily now? If you are, give me a thumbs up. Anyone breathing more? I am. Vous respirez un peu plus, vous sentez le cardio. Okay, you can either sit on a chair or on the mat. I'm going to sit on the mat for now so you can see me. We're going to do a series of exercises called Pow on 1. It's ancient. I want you to extend the toes, sit up straight if you can, squeeze. J'inspire, j'expire, j'inspire, j'expire, j'inspire, j'expire. Next exercise. Bring the feet down. Inhale, come up. Separate the feet, it's easier. Distance of the hips. Exhale, come down, but not too far. Bring your awareness to your ankles. Each time you do this, bring your focus to the joint you're working on. You're going to notice it gets more and more, usually more and more fluid. Okay, now we'll do circles. J'inspire quand je monte. J'expire quand je descends. Sit your more effort, sit with a very good posture. L'autre sens, j'inspire, je monte. J'expire, je descends. It's more important to breathe than anything else with this. Good. Next one, inhale. Push out with the heel. J'inspire, j'expire, je pousse avec le talon. J'inspire, j'expire. L'autre côté, push with the heel. Sit up straight if you can. Inhale, exhale, inhale, exhale. Hold on to the right leg and do very gentle circles. Imagine you're making a circle with your heel. L'autre sens, faites des cercles avec votre talon. Other side. L'autre sens. Good. Place your foot on your lower leg. Put your hand on your knee and stick out your index finger. Imagine that you have a marker on your index finger, and now I want you to draw circles with it. L'autre sens. This helps your hips to move. Other side. Très doucement. L'autre sens. Maintenant, on va faire le papillon. Just plaquez vos pieds ensemble and just place them wherever they're comfortable. Okay? And just bounce a little. Inspirez et expirez. And just come stand up. Let's do a little jiggle. You know, quand on s'assoit pour longtemps, spécialement pour une conférence, ça fait du bien de bouger. L'autre sens. Smile, have a little fun. We don't have to take ourselves so seriously. We don't have to judge ourselves so much. Try to remember what it was like when you were a kid, when you were playful and innocent. Place your hands in front of you. Tirez vos orteils, and now squeeze your hands around them. If it's uncomfortable for you, just do it at your sides or sitting. Inhale, exhale. Inhale, exhale. Inhale, exhale. Inhale, exhale. Lift up the hands and down. Nothing to pain. J'inspire, j'expire, j'inspire, j'expire, neutre. Je remets my thumbs back in my palms. Now imagine you have ink on your hands, and imagine there's a mirror in front of you, and I just want you to make little circles on the mirror, and you're going to be using your wrists like that. L'autre sens. Good. Inhale, come up. Now we're doing the elbow. J'inspire, j'expire. Now j'inspire, j'expire. Place your hands on your shoulders and do little circles. Sens de montre. If you have no shoulder pain, you can bring them right up by your ears and behind you. Squeeze the buttocks, stand into Tadasana. L'autre sens. I always start a little smaller, and then as my joints loosen, I get bigger. This is a great one to do for what I call computer shoulders. Good. Now, turn your head to the right and neutral, to the left and straight. J'inspire, j'expire. Imagine just bringing your ear just gently to the side and come up. Exhale, inhale, exhale, inhale, exhale, inhale. Now imagine your nose is on a window and you've got a red Rudolph nose with a red marker on it. Just draw a circle with your nose against the window pane. Faites un cercle avec le bout de votre nez. Imaginez qu'il y a une fenêtre devant vous. L'autre sens, j'inspire, je monte, j'expire, je descends. Good. Last time, inhale, come up. Exhale, come down. Inhale, come up. Exhale, come down. And for our last 2 minutes, and that's all you're doing, come down on the mat in Shavasana. I'm keeping track of the time so you have enough time to eat lunch. Lie down on your back. I want you to bend your knees. I want you to push up, push your buttocks in the air. Push your buttocks towards your heels. Poussez vos fessiers vers les talons. Maintenant, plaquez le bas de dos au sol. Now, place the lower back firmly on the mat. Okay? Release the buttocks. Lift the head with your hands. Push your head into your hands. And now gently place it on the mat. Extend your arms to the sides, palms up. Extend the right foot forward, the left foot forward. Lift up your shoulder blades, and now plaquez-les au sol, les omoplates. Tirez vers vous vos pieds. I want you to pull your feet towards you. I want you to squeeze your calves. Serrez les cuisses, serrez les fessiers, serrez l'abdomen, serrez les mains, the lower arm, upper arm, shoulders, your face, your head. Squeeze, 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 squeeze. Et lâchez prise. Inspirez et expirez. And we'll take 1 minute to become conscious of the shifts in our body. Breathe any way you want. This is the most important posture for yoga. Prise de conscience. Take one more breath. Interlace your hands, place them behind you. Stretch your hands behind you, stretch your feet in front of you, and release. Last time. Stretch, release, bend your knees, pliez vos genoux, tournez vers la droite. Plaquez la main gauche au sol, push your left hand into the floor. Look down towards the floor and lift yourself up. Come into a sitting position. And thank you all so much. Merci beaucoup tout le monde. Je souhaite la bonne santé. I wish you all wonderful good health. Thank you.
Thank you very much. And now I welcome Dr. Rhonda Zwingerman. Dr. Rhonda Zwingerman is a fertility specialist in Toronto. She actually worked in Mount Sinai Fertility, and then she opened her own full-service fertility clinic. So now she owns this clinic in Toronto as well. Her research interests include pre-implantation genetic testing, early pregnancy care of fertility patients, and obstetrical outcomes after IVF. Thank you so much, Dr. Zwingerman, for joining us today, and the floor is yours.
Thank you. Just going to share my screen. Hopefully you guys can see that. Somebody let me know if you can't. Otherwise, I'll just get going. So yes, thank you for the wonderful introduction. My name's Rhonda Zwingerman, and I'm here to talk about fertility and IBD. And admittedly, I know a lot more about fertility than IBD, so thank you for welcoming me here nonetheless. Okay. So just my financial disclaimer. And then I think more importantly, my other disclaimer is what I am not. So I'm not a gastroenterologist. I'm not a urologist. So this talk will really focus on women and female infertility more so than male infertility, which is probably a whole nother talk unto itself, worthy of its own time slot another day. And although I did train as an obstetrician, someone who took care of pregnant women and delivered babies, I don't do that anymore. I care for people who are pregnant up until about the end of the first trimester, and that's it. So some of the things I'm going to try to cover today, and of course, like, feel free to put questions in the chat at any time. It's hard for me to do talks like this that aren't as truly interactive as when we all used to be able to be in the same place, but such is life, so please ask away with questions. What I'm going to try to talk a little bit about first is about planning pregnancy, about what is infertility, so just some basics in terms of the definition and how it's diagnosed, a little bit about what the common causes are, and then to try to touch on what we know about how having a diagnosis of IBD impacts the chance of having infertility. A little bit about how we, like what we do when people come to see us when they're having trouble conceiving in terms of the testing, and then the treatment. And lastly, I'll try to touch a little bit on specific studies and evidence around whether fertility treatment is just as effective or not in people with IBD. So there's a few studies about that. So in terms of planning for pregnancy, which we sometimes call preconception planning, I think probably the most important kind of take-home message is that any specialists or any physicians who are part of your care team should know that you're planning pregnancy. So I would say, you know, if you are a person with IBD who is wanting to conceive, or even if you are a person with IBD who could possibly conceive because you're in a sexual relationship and not using anything to prevent pregnancy, then I would make sure that your gastroenterologist knows that, because you really do want your IBD to be in remission before you conceive. It's not only important from a fertility perspective, but it's really important in terms of the ongoing risks and how in pregnancy itself. And so there's really good evidence that, you know, having your disease in remission before you conceive is ideal. You also just want to confirm that the medications you are on are safe to continue. And again, I'm not going to get into too much detail about the medications in pregnancy. Again, I think that's another topic, but most of them can be continued in pregnancy. There is some obvious exceptions like methotrexate that aren't used as much anymore. But for the most part, they're safe, and you just want to confirm that. A lot of the things on this slide, they apply to everyone who's trying to conceive or who may have an opportunity to conceive, I suppose. Not specifically just people who have IBD. Smoking, I mean, it's not good for really anything. It's not good for fertility. It's not good for egg quality. It's not good for sperm quality. And so sometimes this can be an opportunity to cut back or even quit entirely if you know you're planning pregnancy. Same thing about cannabis. We know it's bad for, we have a lot of data actually that it can be detrimental to sperm and sperm parameters, less actual data on eggs because it's harder to study, but it's not good for eggs. And certainly do want to stop any other recreational drugs as well. It's important for people who are planning to get pregnant to take folic acid and vitamin D. Ideally, the folic acid would start 3 months before you get pregnant, but at least 1 month before. And the recommended dose is at least 1 milligram a day, and that does differ slightly from the general population, where 0.4 milligrams a day is adequate. But in people who may have some issues in terms of malabsorption, then we do recommend at least 1 milligram a day, and that's easy to find at any drugstore over the counter. And any brand is fine. People ask me that too. And then the other thing you want to think about as you're planning to get pregnant would be to make sure your immunizations are up to date and your Pap test is up to date. Specifically, we think about immunizations for like chickenpox, for measles, mumps, and rubella, because those are not vaccines that we give people in pregnancy. So if you need a booster, it's much better to get that before you conceive. And then in general, you just want to make sure any other medical issues that you may have, for which you may have specialists, are also under control. So, if you have high blood pressure, there are certain medications that are okay to be on and others that are not. I don't know, that's just one example, but if it's depression or epilepsy or anxiety or anything, you just want to make sure if you have a specialist that they know you're trying to get pregnant and that you review your medications with them and anything else that you might be on to make sure that they're okay to stay on while you're conceiving. And then the last thing is to think about whether any genetic screening is warranted. And this could apply equally to pregnant woman or man, and I use those terms understanding they don't apply to everyone. But any person who's planning to provide egg or sperm to a pregnancy need to think about if there's genetic risk there. So that could be as simple as reviewing your family history and thinking about if there's any genetic diseases that you already know run in your family that you should think about getting tested for yourself. Sometimes this is based on ethnicity. So for example, for people who are of Ashkenazi Jewish background, as I myself am, there's a special, we know that people of that background are at higher risk for certain genetic diseases, and you can actually get a blood test to check for, at SickKids, it's 7 common genetic diseases that are more common in that population. Sometimes if it's people of African descent, we screen for sickle cell disease, things like that. And then what you're gonna start hearing about more and more are these, what we call direct-to-consumer tests. So tests that can basically arrive in a package in a kit right at your house that you spit into or swab your cheek, and they'll screen you for like 200 or 250 genetic diseases to see if you carry anything that you could pass on to a child. And usually both you and your partner would have to both be a carrier for that same thing to risk passing it on. So the chances are generally low. But as there's going to be more and more, I think, of that coming in healthcare that we start hearing about. So just another thing to think about before you get pregnant. Okay, so turning now to infertility, the kind of quote unquote textbook definition or how we generally think of infertility is the failure to achieve a successful pregnancy after 12 months of regular unprotected intercourse, or due to an impairment or inability of somebody's ability to reproduce, either as an individual or with their partner. So that might be if there are 2 female partners, they don't have sperm, they're obviously not going to be able to get pregnant on their own, and they're going to need some help. Infertility is very common. The number is probably much debated. The common thing you'll see is 1 in 6 couples. I think that's for sure true. That, of course, only applies to the first half of this definition on the screen, but it is very common. It is not something that everyone feels comfortable talking about. And so what I hear all the time from even friends, but also patients, is that as soon as they share their story, then out of the woodwork, they start hearing from all of their friends or their work colleagues about their struggles with infertility as well. And that certainly happened when I was just launching my new business, is that as we were kind of speaking to potential investors, everyone came out with their own fertility story. It was quite remarkable. A really common question that I get asked by people, by physicians, by everyone is like, when should I get help? When should somebody come to see somebody like me? That's really the question here. And so generally we would say after 1 year of trying to get pregnant, if the female partner is less than 35 years of age. And we would generally say after 6 months of trying to get pregnant, if the female partner is older than 35. And then I would also add that if people are able to get pregnant, but they've had 2 or more early pregnancy losses, which are also sometimes called miscarriages, then I would seek help from a fertility specialist. Now, this presumes that the female partner is having regular menstrual cycles, regular periods. And there's no obvious already known reason why there might be trouble in terms of conception. Some people will even say if the female partner is over 40, you should wait even less than 6 months, more like 3 months, just because we know age is a kind of a significant factor here. So I just said that. So I would say, for people to ask their family physician or any physician for a referral to a fertility specialist sooner than what I put on the previous slide, if any of these things apply. And so it doesn't need to, it can be any doctor that refers to a fertility specialist. So if you're in a situation where you need access to donor sperm or donor eggs or a gestational carrier, which is sometimes called a surrogate, then you should just get a referral right away. So that might be people who are single, people who are LGBTQ and trying to build a family using donor egg or sperm, or if there's just any other reason why that might be necessary. Like I said, if people who are over 40, if the person who's planning to conceive has irregular periods, so usually we would say more than 45 days apart, or no periods at all. If there's already something in your past which is well known to have impacted fertility, so past chemotherapy being like a very obvious maybe example of that. Another would be surgery of the ovaries or uterus. And then if you have an inherited disease, like you already know about that, and you're coming to see me, maybe not because you're having trouble getting pregnant, but specifically because you don't want to pass that disease on to your children. What causes infertility? That is a very good question. Many, many different things. Some people or couples have more than one cause occurring at the same time. And the truth is that a lot of times we actually can't find the cause. Sorry. So as many as 1 in 5 couples that I see have what we call unexplained infertility, where we don't know why they're not getting pregnant. Sorry. These are some of the examples of causes of infertility. Oh my goodness, this tickle. I'll just chug some coffee. Hope it gets better. So advanced age is a very common one. It's often tied to low egg reserve, although those two things don't necessarily go together. Not ovulating regularly or at all, like I mentioned. Blocked tubes or scarring in the pelvis, which is specifically important or relevant in people with IBD. Endometriosis, which is a very common gynecologic condition that is a bit elusive and people don't know a lot about. But it can cause pain, painful periods, painful intercourse, and often infertility. I'm just gonna go get water if that's okay, and because otherwise this is quite ridiculous. 1 second. Okay. Oh, Zoom presentations, right? Okay. Okay, sorry about that, guys. So uterine fibroids problem, which is a benign tumor of the uterus, very common. Usually don't cause fertility issues, but occasionally can. Sperm issues, as common as egg issues. We just don't think of it like that. And then sexual dysfunction, which is, again, a topic that maybe is harder to talk about for a lot of people, but probably even more important to think of in the context of IBD and some of the challenges that come with it, and probably a whole talk unto itself. In terms of the impact of IBD on fertility, we know from many studies that women with IBD have the same chances of conceiving naturally as women without. So that's a really important point. I think there's a lot of misperception that actually that's not true. Now, there are two exceptions to that rule. One is that women who are during or immediately after a flare do have lower fertility around that time. And that's probably due to an inflammatory response. The second is that after J-pouch surgery, there is a higher chance of having blocked tubes that can lead to infertility because of blocked tubes. There is also some very, very new emerging evidence, so that there may be more likely to be endometriosis in women with IBD, as in those two diseases may be more likely to be found together than just by chance alone. But I would say the evidence is very early. We're only just starting to understand the association between gynecologic diseases and IBD. A lot more research has been done in pregnancy and obstetrics than in gynecology. Now, even though we know that women with IBD on the whole have the same chance of conceiving naturally as women without, we also know that women with IBD are more likely not to have children than women without. So I think, well, why is that if it's not because of more infertility? It's for other reasons. And what are those other reasons? I mean, you guys would know better than me because I'm speaking to a population of women who are living this truth. But there are some studies that show that women with IBD have more fear of infertility, more concerns about maybe passing it on to their children, about the safety of being pregnant, the medications in pregnancy. And so for whether it's a choice that they want to make or a choice that they feel that they have to make, where women with IBD choose not to get pregnant. In terms of what we do for fertility testing, when we see people who are having trouble conceiving, I usually like to split it into these three categories. So for sperm, we do a semen analysis. For eggs and ovaries, we want to check two things. We want to check if people are ovulating regularly, and we can often do that just by history alone and asking questions about people's periods. In terms of checking their egg count, which is sometimes known as an ovarian reserve, we can do that with hormone testing of the blood and with ultrasound testing, and that's usually an internal or vaginal ultrasound to take a really close look at the ovaries. And by putting those pieces of information together, we can get a sense of if the egg number is kind of average for age, high for age, or low for age. It's not a precise test, but it's the best that we have. And then when we think about checking out somebody's uterus and tubes, there's two different tests with very similar sounding, very long names that can check that out. The first is a sonohistogram. That's an ultrasound-based test that uses air bubbles that we can see on the vaginal ultrasound to check that the uterus is a normal shape, and that the tubes are open. It's slightly better for looking at the uterus and the tubes, looking at the uterus, and it's very good for tubes. But if there's some question, about specifically you want to really, really, really do the best test that's out there for tubes, it's probably this other one called a hysterosalpingogram, which is basically an X-ray dye test where we put X-ray dye through the cervix, comes out the tubes, and we take an X-ray. Neither of these tests are at all fun to have. They're quite uncomfortable for most people, and so we only do them, you know, once when we first meet people, or if we think something has changed where we're really worried about the status of the tubes. What sort of fertility treatment do people get? Well, it depends on why we think they're having trouble getting pregnant. Sometimes it just depends on people's own values and preferences and how aggressive they want to be with treatment and how quickly. And unfortunately, it can also depend on financial resources, because a lot of fertility treatments are not covered by what is OHIP in Ontario or by other provincial health plans, and also by geography, because some people live in urban centers where they have ready access to a fertility clinic, and other people live very far away from a fertility clinic. So just as a high level overview of what's out there, there's kind of 3 types of fertility treatments. The first is what we call ovarian stimulation. It's basically fertility pills, where we try to get people to, instead of release 1 egg every month, release 2 or 3. Just statistically, if there's more eggs around every month, more chance that one of them is going to work, get pregnant. Intrauterine insemination, or IUI, sometimes called artificial insemination. It's basically a process where we take a sperm sample, concentrate it into a teeny tiny volume of fluid, and put all the best good swimming sperm past the cervix into the uterus. It's kind of like having a pap test. And it gets more sperm closer to the eggs. And so you can combine 1 and 2 together, which we often do. Intrauterine insemination can be helpful if the sperm count's low. It can also be very helpful if people are having a lot of any sexual dysfunction or sexual pain, as a way to kind of get the sperm and the egg to meet without having to have intercourse. And then the third is in vitro fertilization, or IVF, which some people call like a test tube baby. It's when we take a sperm sample and then we take eggs, we combine them outside the body in the lab to make embryos. Just to kind of briefly walk you through what that process looks like. We give people fertility drugs so that they make a lot of eggs. Then we take the eggs out in a procedure that we do in our clinic. We mix the eggs and the sperm together. We grow embryos in the fertility lab, usually for 5 days. And then we can either put an embryo back in, or sometimes we can freeze the embryo and put it back in at a later time. We can do that just if you want to, because maybe you don't want to get pregnant quite yet. Maybe actually something is happening, you're worried you're having a flare, your disease isn't controlled, something needs to be adjusted with your medication. You can freeze the embryos, make sure your health is optimal, and then put the embryo back in at a better time. Sometimes we do this for other reasons related to the fertility kind of protocol that we use. And then sometimes we'll actually biopsy or test the embryo before we freeze it and then put it back in. Again, something I can talk about ad nauseum another time. Does IVF work? I mean, it works, otherwise no one would come to me and I'd be out of business pretty fast. But the truth is it doesn't work all the time. It doesn't even work the majority of the time. So if you see the different numbers on the x-axis here are the age categories of the women whose eggs are being used for IVF. And that is always, no matter what study you look at, no matter what research you do, the kind of one of the biggest predictors of whether or not IVF is going to work. Because as women get older, their eggs get older. Women are born with all the eggs they'll ever make. And those eggs accumulate genetic errors. And those genetic errors make it less likely that any given egg is going to lead to a pregnancy or a baby. And so that's why, and because we don't know how to fix that, we can't, there's a limit to what IVF can do to overcome age-related fertility issues. On the other hand, I would say a lot of people who maybe have IBD and need IVF, it would be because their tubes are blocked from surgery. And actually in that case, IVF has higher than average success rates because that's exactly what IVF was invented for. It was invented as a way to circumvent the tubes or work around them. The very first person who had ever had a baby from IVF, she had blocked tubes, and that's why they were doing IVF. So which I guess gets me to this next slide quite smoothly. Most studies, specifically about women with IBD undergoing IVF, show that it works just as well, assuming that the disease is in remission. So that's a big caveat. The most important predictors of pregnancy are age and egg reserve. That's true for women with IBD. That's true for everybody else doing IVF as well. So it's no different. And in fact, I would say there are some studies, like I said, that show if the reason you're doing it is because the tubes are blocked and you need a way to circumvent that. Usually the pregnancy rates are on the higher side because it means the egg quality and the sperm quality are usually good. And you're doing this for a reason related to tubes. Unfortunately, we really don't have any studies that look at the outcome of other less invasive fertility treatments in women with IBD. So I looked really hard to try to find any papers about insemination or fertility pills in women with IBD, and I really couldn't find any. That data is a little bit, IVF data is pretty well tracked because every country usually has a database for their whole country of all the IVF data that they have to report. But it's not true for insemination or fertility pills or other types of fertility treatment. And so we just unfortunately don't have that data yet, and I wish we did. So to kind of share some conclusions, I would say preconception or pre-pregnancy planning is very important. Infertility is very common, both with and without IBD. I would recommend, and obviously as a fertility specialist, I'm slightly biased, but I would say seek out someone like me sooner rather than later if you're having trouble conceiving, because the process does take some time. So it will take, some time to get the referral, to be seen, to have the investigations, to get those results before you can even make a plan and then start treatment. And so you just want to factor in some of that time when you're asking your physician, whoever that may be, for a referral. And then the last thing is treatment is available. So if people are having trouble conceiving, which is common, there are lots of options that are available to try to help. And then lastly, I would like to apologize for the tickle in my throat. And I think now I would be happy to entertain questions. So I'm going to stop my screen share, and hopefully Cindy will tell me if that's the wrong thing to do. Okay.
Hi, Dr. Zinger. Nice to see you face to face.
Yes.
So I'm looking, I'm looking just in the chat right now. Does anybody have any, I didn't see the whole chat the whole time. For some reason, I only saw private messages. Okay, if anybody has any questions, let me know. I have a few questions that I was just thinking about as you spoke. If somebody, they weren't planning on getting pregnant, but then they are in a flare-up, a woman is in a flare-up, and she happens to get pregnant. Is there any guidance that you can give somebody because that accidentally happens, and how could they manage that? I mean, what are the recommendations if that happens?
I mean, it's a good question. I'm not sure I'm the best suited to answer it since I don't tend to see those patients. Because those patients would probably go to the obstetrician.
Mm-hmm.
So, I mean, there's always ways to deal with that, right? So, I guess I would say, and this is just me speaking as somebody who is a huge supporter of people just making their own choices, whatever is right for them, regardless. So if they want to be pregnant, then they should stay pregnant. And, the GIs and the OBs will talk to them about their treatment options. There certainly are ways to treat flares in pregnancy. Mm-hmm. And if they don't want to be pregnant, then they shouldn't be pregnant.
Right.
Like that's what I would say. And just, it's a good reminder that even people who, I think because there's more fear of infertility, people may, and I don't know if this is true or not, but people may not be as, people might think, oh, I'm probably not going to get pregnant, and maybe not be as diligent with the contraception. And so it's still important if you don't want to be getting pregnant, or maybe you want to be getting pregnant, but you're actually in a flare and you want to wait until that flare has passed before you conceive to make sure you're using some form of contraception, whether or not that's pills or condoms or timing or whatever works for you.
Okay, some other questions. What causes pelvic scarring and what are the solutions?
Yeah, so that's a good question. So, you know, the most common causes of pelvic scarring would be an infection. So sometimes those are sexually transmitted infections like chlamydia and gonorrhea, right? We know that those can, if you get them, they can kind of ascend or go up the reproductive tract into the pelvis and lead to scarring. And often that's asymptomatic, so you would never know until years later when you want to get pregnant, and then we test and see that the tubes are blocked. So it can be an infection, and if that's an infection related to IBD, you may know it wouldn't be so asymptomatic. And then the second one would be surgery. So those are kind of by far the most common would be, so sometimes it's a burst appendix, right? Usually a straightforward, I got my appendix out, doesn't affect the tubes, but if you had some sort of complication, it was infected, it burst, like I've seen that can affect even, especially the right tube. Or if you've had surgery on your ovaries or surgery on your, you know, your colon, like the rectum and the colon, they're all right there beside the uterus and the ovaries or the tubes. So those would be the most common. In terms of solutions, it depends what problem it's causing, right? If it's causing pain, I guess that's one thing. If it's causing infertility, it's kind of separate. So sometimes surgery can be contemplated, but surgery itself then can just make new scarring, right? So you have to think that that's not always a straightforward decision to make. If it's fertility related, then IVF is sometimes the solution because it is a complete, basically, workaround. You just don't need your tubes. So yeah, it kind of depends. Yeah, but what people ask me a lot is, can we fix my tubes? Can we do surgery to open them up again? I mean, there are like very occasionally, right? Sometimes we can try, but it's not always, certainly not often. Doesn't always work. So we can try, but usually it's not the way we go.
Okay. Another question is, did you hear me? Sorry.
No.
No. I said, how do biologics affect IVF treatment and pregnancy?
So this is a very good question. I will maybe only speak to the first half of that. I'm not aware of any specific studies. The short answer is you could be on your biologic and you can do IVF. And I have not seen or heard or read anything that specifically raises a concern about that. In fact, I would think that it's much better that people be on their biologic than try to stop it or change it or risk their disease kind of flaring. So there's not a lot of studies exactly about that, but I don't think there are any specific concerns either. So in general, my understanding is most of the biologics are okay in pregnancy. There's questions around the dosing schedule and when you get the last dose, which I won't speak to, but yeah, basically if you're on a biologic and your GI knows you're trying to get pregnant, then I definitely will not at all interfere with it while you're undergoing fertility treatment.
Okay, and another question, how long should there be a relapse between a flare and trying to start conceiving? Like how long a period of time?
That's a good question. I don't know if we know the answer to that. I would say as long as you are not, like as long as it's, you know, your doctor, your GI, if they looked at you right then and there and they would said, you know, you're not having a flare or you're in remission, then you can start trying to conceive. It's usually not instantaneous, or at least from my perspective, because I see people who obviously have trouble conceiving, right? It can take a few months. So I would worry about kind of prescribing too long of a timeline to wait of being in remission. So I think once you're in remission, it's okay to start trying.
And what about, this was from the same person,
Mhm.
what about if somebody has frequent flares and has difficulty maintaining long periods of remission?
This is hard, and I think this is actually not only applicable to IBD, but other autoimmune diseases sometimes. So just thinking about, there's a thyroid condition called Graves, and it's like an overactive thyroid, and same thing. Like I can think of a situation where it kind of we struggled with the same thing. I mean, I think you have to do your best, right? So we know age is also a factor. And so if it's not reasonable that one will ever be in remission in a sustained way, then you're not going to wait for something that is not reasonably going to happen. You may then have to just accept that the fertility rates are going to be lower, right? And that the pregnancy risks are going to be higher. And in my opinion, as long as you know those things, then ultimately it's your decision to make, right? Along with your care team. So it's not ideal, but often we're not working under, not every situation, not every person's physiology reads the textbook, as we said, right? So I think that, like, as long as you know that that's the goal, you may say, okay, well, that can't be the goal for me. That's unrealistic. Like, what else can we do to just make this risk as low as possible in my situation? Another thing, I mean, I'm not sure I would, in fertility medicine, we can freeze people's eggs or freeze people's embryos to use later, right? And if you're worried about age, 38, 39, 40, and you think, hey, I'm going to get in remission, but it's going to take me another year or two, then I don't know, maybe you think about freezing something so that you're not, trying to get pregnant with 41 or 42-year-old eggs, which is a much harder endeavor than with 39-year-old eggs.
Right. Another question was, do women with IBD have more pains or cramps during pregnancy?
That's a good question. In pregnancy, I don't know. And in terms of with their regular menstrual cycles, I don't know. Like, I think that we have barely scratched the surface in terms of studying gynecologic conditions and IBD, right? So in pregnancy, there are many challenges because the hormones of pregnancy makes your gut slow down and gives people, even who were previously had no heartburn, like the worst heartburn of all time. Like, there's a lot of changes to the GI system that I'm sure can be a challenge to work with. But to me, I think more about, like, what about people's monthly, like, period cramps, and are those worse? And I think about what about pain with intercourse, and is that affected? And I don't think the studies have been done about that, to be honest. And it's so, because one of the challenges is we know the best pain medication to treat painful periods are anti-inflammatories like Advil and naproxen, and sometimes you can't use, there's like a lot of different factors. It's not so straightforward, but yeah, it's a very good question.
I know you mentioned earlier, to try not to get pregnant during a flare-up, and we talked about it before. Is there anything that people who are having fertility issues, who have IBD, can do to help them get pregnant? Is there, besides for trying not to get pregnant during a flare-up, is there any other things you can guide people to do, whether it's eating or supplements, or is there anything particular?
Just the question that everyone asks me. Yeah,
like, especially those having a hard time. Obviously, a lot of women have a hard time getting, even especially those who have IBD. Is there anything that you recommend that they could do to increase their ability?
Yeah, so I mean, I think a lot of the advice is the same that I would give everybody. And I always tell people it's not rocket science. If there was some like silver bullet here, like, I wouldn't be keeping it to myself and you would know about it. And unfortunately, like, I think a lot of the stuff that's out there is not backed by good science, right? People spend a lot of time and money and effort maybe on things that are of debatable impact, but like, it's like, don't smoke, don't use marijuana. Like, it's really the big things, like minimize your alcohol. The other thing is, there is data that having, your body mass index in an optimal range, right, is better for fertility. And sometimes in the population of people with IBD, I actually more worry about people who are underweight, right? So if people are underweight, that can affect their ovulation. And sometimes even if people are having regular monthly cycles, but they're underweight, we can see that represent as in much more subtle ways in terms of fertility. And again, it's more anecdotal than anything else at this point, but sometimes we see people who have kind of a thin lining of the uterus and it doesn't thicken well to let an embryo implant. We think maybe there's an association between having kind of a lower than ideal body weight and that. So, you know, that's where a dietitian or somebody can come in handy as well, because sometimes actually gaining weight can help if they're underweight.
What about taking hormones? Is that with somebody who has IBD? Is that anything you recommend?
So depends what you mean by taking hormones, right? Because if you take hormones one way, then you get good birth control. That's what the birth control pill is, right?
The other question.
And even if you just took estrogen all the time, you would not ovulate. So, you know, taking either birth control when you need it or fertility drugs, which are hormones, when you need it, but not wanting to take, for example, like I do worry that sometimes some herbs or supplements or traditional Chinese medicines have estrogen-like effects. And if you take them at the wrong time of your menstrual cycle, or if you're not sure, they can actually stop you from ovulating or impact fertility. And so I wouldn't do anything without speaking with a physician about that. Because it's usually, the hormones are usually the symptom of whatever's going on, right? So when our menstrual cycles are working normally, they make all the right hormones that we need. And so if our hormones are right, it's usually an issue around ovulation or something like that, that's what needs to be addressed rather than the hormones. So I guess like in terms, and the other thing I always talk to people about is timing. So sometimes people don't know when in the month is the best time for them to try to conceive. And I think there's a little bit more knowledge about that with all of the apps that are out there now in terms of menstrual cycle tracking. Published a paper where we looked at 140 period tracking apps to see which ones were good.
Which one do you recommend?
So I don't know if I'm allowed to like say names of brands that is totally independent. Nobody paid me anything. I really like Clue. That's my favorite. But we did our study before Apple came out with their own in the health app. So that one, I don't know, that one might be good too. You just want one that seems kind of smart, where as you enter more data, it changes its predictions, not one that you just put in my periods are every 30 days and it just counts for you every 30 days. Like you can do that on paper. So just understanding that, you know, really there's only about 5 days a month where you can get pregnant. That ends on the day that you ovulate. So you want to err on too early in the month, not too late to have sex. If you have sex only after you ovulate, your chance of getting pregnant are 0.
Wow. Okay.
And so for most people, if they have like a 28, 30-day cycle, that's like days, you know, 11 to 16 or thereabout, like in the middle. And just even tracking and being more aware of that can help people.
Okay. So, and another question, what about people who are on like biologics and Humira and all of that? And how does that interact if they want to get pregnant or they need to be on any kind of estrogen? Is there an interaction? Is it safe?
It's a good question. I think it's fine is the short answer. Okay. In fact, yeah, so the one thing I always not worry about, but am aware of is that of all the different fertility drugs that we use, progesterone is the one that tends to have a lot of side effects, and including GI side effects. And so I wonder if that might be even more true in people with IBD. They may, like, especially if you go from being on progesterone to stopping it. So if you were on the pill for a long time, you stop it. Sometimes that withdrawal, people can have kind of side effects or symptoms, but it's not an interaction, right? It's just the nature of the medication. No, so it's fine to be on your biologic while you're taking these medications. In fact, there was a fair amount of interest using Humira to treat recurrent miscarriage at some point.
Wow.
I was speaking with Dr. Laskin, who's a big recurrent pregnancy loss expert here in Toronto, and he tried to do that study. It couldn't get it done for a number of reasons, but just thinking that maybe some, you know, some underlying causes of miscarriage are immune related. And so which just always gives me some reassurance that it's okay to use in early pregnancy if they were planning a study where they gave it on purpose to people in early pregnancy to try to help.
I have another question, but I have another question following that. Would you recommend, like, somebody who's, you know, has a lot of flare-ups and is being seen by a gastro, would you work with the gastro? If like, how does it happen? Do you work together, like gynecologist with the gastro?
So I obviously can only speak to myself. Like, we just need, generally, this is not something that our healthcare system is particularly well set up for. But in modern medicine, like, we need way more of this, right? And it's more about logistics than anything else, because it's often like, you see me, I write a note, it gets faxed to them because it's 1900, and then they see them and they write a note, it gets faxed to me. So it's more like overcoming somehow the old-fashioned technology or the fact that we're all busy. But absolutely, like, now we can securely email, you know, between physicians and pick up the phone, God forbid, and actually talk to each other. So yes, one of the things that I'm planning my new clinic. It's not open yet, unfortunately, but, you know, is how to kind of really work out those ties with other physicians. I just want to, can I clarify something I see in the chat?
Yeah.
Somebody asked about Chinese herbs and acupuncture.
Yeah, I was just going to ask you that. Yeah.
So let's separate those two things from each other. Acupuncture is okay. The evidence that so it's not harmful. If you want to do acupuncture, go to acupuncture, right? For fertility. The biggest study that we've done to date from like a Western medicine view of acupuncture, where we basically took not me, but they took a ton of people doing IVF and half got acupuncture and half didn't. The chance of actually taking home a baby at the end of the day was no difference between the groups, but there's potentially a lot of other benefits. Some people find it relaxing and helps them with their mood, whatever else it is. So there's no harm if you want to do acupuncture, that's fine. I'm slightly more concerned about Chinese herbs only because I don't know what's in them. And there's not really a good way for me to know for sure what's in them. And sometimes they can have hormone-like actions. They can act like estrogens, which could theoretically then interfere with some of the medications that we're giving people when they're doing fertility treatment. So that's my party line. That's kind of what I tell people when they ask.
Your party line. Well, I think that will be the end. I don't see any other questions. I know I gave you a couple questions, so I just wanted to take the opportunity to thank you so much for participating in this, for making time on a Sunday. I know you're busy and you have 2 little kids, so thank you so much for sharing this great knowledge. I thought it was amazing and very helpful to people who are definitely interested in getting pregnant or having issues getting pregnant clinic. But they could follow you on Twitter at the R Swingerman MD.
Right.
So they could follow you. Could they send you a message through there as well?
Yeah, you can send me a message. Our new clinic is just about to hopefully start construction soon, so we don't yet have a name. Otherwise, I would tell you what it is.
Okay.
A whole long story there, but hope to open mid 2021, so in the summer. So yeah, for now, you can follow me on Twitter and or message me in the chat here in the next few minutes if you want.
Okay. Well, best of luck in your new clinic.
Thank you.
And thank you so much. Does anybody have any additional questions? The only question I want to ask you, in terms of, you said something, the lining in the uterus, when people are thin and have IBD, besides for diet, is there anything else that they can do to strengthen that lining?
So I guess first I would repeat that this is anecdotal. So there's not this is like, you know, I used to work in a practice, there was 9 fertility doctors and we'd all be like, hey, like this kind of a pattern where we see where people who are really like kind of borderline underweight are more likely to have this issue with thin lining. Sometimes fertility treatment can help. But it's not something that we yet understand fully, right? In fact, the Canadian Fertility Society just put out a guideline for physicians, for fertility doctors, about how to treat people, how to manage people who may have what we call a thin lining or a thin endometrium during fertility treatment. And basically, there's a lot of things that have been tried and no clear one way to go or anything that works better than others. So I guess the short answer is like, yeah.
Lots to research and
lots
find
to
out.
research, yeah.
Okay,
Absolutely.
well, I thank you so much on behalf of Crohn's and Colitis Canada, on behalf of the Fisher family, and for taking part in this Jaclyn Fisher Education Symposium. It's so appreciated. The topic was amazing. Thank you for your time today and for putting together the presentation. And I will let you go because our next presentation is at 2 o'clock.
There you go. Thank you so much, Cindy.
And I hope your tickle has gone. Thank you. Take care. Have a good rest of your day. Bye.
So now, without further ado, I want to introduce Dr. Martha Dirks. Thank you very much, Dr. Dirks, for joining us today and for giving your time for this wonderful and important event. And just a little bit about Dr. Dirks. So she has 18 years of clinical experience, and primarily it's actually in IBD care. And she was the treating physician of Jackie, as you heard the introduction, Jaclyn Fisher, and who are the ones that are sponsoring this event. So she's the pediatric gastroenterologist at Saint-Justine, and she's an assistant professor of pediatrics at Université de Montréal. And she's also the director of gastrointestinal endoscopy and video capsule endoscopy. You have a lot of roles, Dr. Dirks. So without further ado, I'm gonna allow you to continue with your presentation. Thank you very much.
Bonjour, hi everyone. Thank you for sticking it out to the end to hear the final presentation. So I want to thank Crohn's and Colitis Canada, especially the Montreal chapter and the Jaclyn Fisher Foundation for this opportunity. And we'll get started. So hold on a second. Hold on, here we go. So I'm here to talk about actually transition of IBD care from the pediatric setting, which is of course my home, my milieu, to adult GI care, and what are the steps to get someone to a successful transfer of care where they are well and happy, autonomous, and in control of their IBD. So I have no specific conflicts of interest, and so we get started. So the pediatric IBD care model is very family-centered, even though we're centered on the patient in terms of caring for the individual in their IBD. A lot of the communication between the healthcare providers and the family is really centered on the parents, especially in the younger years and the early adolescent years. But of course, a lot of teens with IBD are diagnosed in adolescence, and the time passes very quickly until they're ready to be transferred to adult care, which the standard of care here in Quebec is around 18, and we'll get back to that. So in addition to that, now you all have to navigate the additional steps of health protection and community prevention of COVID-19. So teens have a lot to deal with when they have IBD, and school, and the masks for appointments, and now additionally booking appointments for blood tests, radiology, etc. in advance. So it's a little bit more complicated time than it used to be. This is a snapshot before the pandemic. So in 2018, approximately 270,000 Canadians were affected by IBD, and about 7,000 of those are under 18. Giving a prevalence of 671 per 100,000 residents here in Quebec. And at Saint-Justine, courtesy of my colleague Prévost Chanchou, who gave me this slide from our IBD database, we have had, on average in the last few years, about 120 new cases of IBD per year. And in 2020, I'll keep you posted, but it's more like the 2018 levels. So from that first moment where there are symptoms and a first visit to a family physician, or maybe an emergency department if someone doesn't have a regular healthcare provider, that young person comes to us in Peds GI, gets their scope, a diagnosis is made, a treatment discussion is made, and a big multidisciplinary team with somewhat overwhelming, I think, at the beginning, meets the family at diagnosis. And after that, hopefully things settle down and the follow-up visits are more quarterly in the adolescent years. And through that time, there will be imaging, blood tests, fecal calpros, a control endoscopy or two, depending how things are going. Maybe a relapse, we hope not, but it does obviously happen. Till finally, sometime in that 17 to 18-year range, we're talking about transferring to an adult GI. So when we talk about transfer, before transfer, there's the process of transition, and that transition is that planned process of developing the skills required so that a young person has optimal disease control, but also well-being globally when they arrive at transfer to their adult GI and the new healthcare team. And in peds in general, that transition process for other conditions especially starts around 12 to 14, and they have a long time to do that cheminement, make their way towards 18, learning more about their disease, starting to ask more questions, being alone a little bit with their physician at visits, starting to program appointments in their agenda, starting to book their own appointments, starting to make their own calls to IBD nursing. But the particularity about IBD, unlike other pediatric disease models where we talk about transition like in cardiology or like in for children affected by cystic fibrosis, is that often the disease onset is somewhere right in the middle of this. And so right at diagnosis, the median age is somewhere around 15, and you have to both learn about a new condition, adapt to a new condition, and then not so far in the future, be ready to be taken over by a new specialist. So what are those key personal determinants for a successful transfer from pediatric to adult care? And I would say this is my list, but it's supported by the literature, is that you have to have adequate self-IBD knowledge and IBD knowledge in general. The young person has to have enough autonomy from their parents. They have to have some self-efficacy and decision-making skills, meaning that they can manage their day-to-day life and day-to-day decisions and some of their disease-related maintenance day-to-day organization. They need support, both from a community of friends and school and a family support. And they need to have resilience, both personal skills, which I'll come back to in a minute, and an environment that supports them in that resilience. So in terms of knowledge requirements, this is sort of a series of pictograms thanks to the design department at Saint-Justine to just give you kind of a visual of what you need to know and remember. And what I would say is that young people have to know themselves, so not just their IBD, and I'll come back to that, but who they are as a person, what their preferences are, what's their learning style, how do they stay organized, who they need support from, what are their special needs, if any. They need to know who their docs are, both pediatric and later before they leave, who their adult GI is and how they're going to reach them, as well as maybe their nutritionist, their IBD nurse, a psychologist if they have one, a social worker if it was helpful, and ideally have a family doc. But if they don't have one, really need to be on a wait list for a CLSC to get a family doctor, because in pediatrics, the pediatric GI will do a lot of primary care just because of the way the health system works here in Quebec. But that's not so true on the adult side. They need to know where their labs get done, whether they're actively participating in a research study that's longitudinal and maybe they'll get a phone call about in future years. Knowing about their meds and what happened in the past in terms of surgery. Having an emergency plan when things aren't going well, and knowing when their last tests were in terms of scopes or imaging that might be pertinent, like an MRI. So to get to that level of knowledge, it's really a partnership between the healthcare team, the family, and the patient or the young person who has IBD to get that knowledge. And the first part is knowing my IBD or your IBD. So where is it Crohn's or UC? Where is your disease location? So, if you have aphthous ulcers, is there gastritis associated with Crohn's disease? Was there small bowel involvement? Are your symptoms of a flare usually relate things like diarrhea, blood in the stools, or a recurrence of a perianal fistula? Or is it more getting constipated, feeling tired, not just not being well? Knowing whether in the past, were there any nutritional status problems, and was there pubertal delay? And was there growth delay? And is actually around 18 that young person still growing? And it's an important point to carry forward. Were there liver enzyme issues, either due to medications or because there's a second IBD-related liver disease, like sclerosing cholangitis or autoimmune hepatitis, that causes them to be elevated? And are there other issues like anemia or low vitamin D levels, skin problems like psoriasis before or related to treatment? Were there kidney stones? And I really would focus a lot on the last part. What's happening in terms of emotional health? Have there been moments of, severe stress, difficulty coping, anxiety, or even depression? So that's the sort of knowing about the self, and then you need to know about the treatments that you've had. So medications that you've had, vaccinations that you've had, any blood transfusions that you may have had, and any reactions to those that you may have had in the past. And the healthcare team is really supposed to help you. In PEDS, a lot of it's done by the clinical nurse specialist, the coordinator, the nurse, your doctor directly, organizing blood tests, MRIs, and so on. But that's going to fall more to the person themselves, with a requisition to phone, to book, to organize after the fact. And you'll need to, that person around 18 is going to need to know, and even before, what are the precautions that they need to take at school or otherwise. So, to come back to this idea that there are milestones over time as you get, as the person gets older, it starts from having some initiative to start knowing a little bit more about what IBD is and taking their own medication with a parent support who checks, to later on, entering in their own agenda when their appointments are, phoning the nurse coordinator or phoning the secretary, making sure they have themselves the right notices for school, special attestation for school, for exemptions, for absences, for things like, Remicade infusions, to appointments, to radiology, to counseling, whatever it is, to the moment when they're ready to be transferred to adult care, when really everything from booking to transportation will fall on their shoulders. So I would say that this is sort of a helpful schematic to keeping an eye at each appointment, starting in the adolescent years, let's say around 13, or at diagnosis if it happens at 15, that at each appointment, come with a question for the IBD nurse or doctor. It's not just it'll be more directly with the pediatric gastroenterologist of what you feel you need to know this time, and what skill you want to work on, and what skill the teen wants to work on. Is it making their own appointment? Do they have, is it about nutrition? Is it about, absentee from school for appointments? Whatever it is it about sexuality? That they have a question that they bring to the appointment, and that at the end of the appointment that their question is answered, and they try and set a goal for a question for next time. Even if they don't make it that day at the appointment, that they think about it for next time, and that they bring it to the appointment so that they work on their own agenda, what they want to know, their own autonomy. So in terms of going back to the determinants of a successful transfer, let's say you have adequate self-IBD knowledge, where your disease is, what's affected, what your treatments are, what the side effects of the disease, of the treatments were, what some of the nutritional issues were, that your decision-making skills for booking appointments, writing things in your agenda are okay, and you have good family support. So besides that, what are the two other factors? Well, we talk about self-efficacy and resilience. And why is that relevant? Well, actually, because young people with IBD don't necessarily have the same top concerns about their transition or transfer to adult care than their parents do, or that their doctors do. So this is a study that was done by a PhD nursing professor, Dr. Gray, and she used a track questionnaire, a questionnaire for transitions with patients, their parents, and physicians. And this is a US cohort, so they're older. They're 17 to 23. And these were the top answers of young people. They really wanted to make sure that they knew, that they could call someone, that they recognize their signs of a flare, and that they were covered for insurance so that they could be reimbursed for the care that they needed. And for them, they were a little less concerned about taking their medications correctly and independently or filling a prescription, because actually they had achieved those milestones from their point of view, but their parents and physicians were not always as convinced. And I think this is just, put this slide up just to say that most teens who transition to adulthood with IBD are doing well and are doing well scholastically. This is a study that Harbinder Singh and Charles Bernstein did from Manitoba, looking at language scores amongst grade 12 students who had Crohn's or colitis. And it's interesting because it comes from data across the province, and except that girls do a little better than boys in language skills in general, which is sort of nice for talking about, kids with IBD did just as well as everyone else, unless they had a mental health problem that was not well controlled in their grade 12 years. So it wasn't really the IBD, it was the IBD and other mental health struggles that affected school performance. So because of that, it falls on the pediatric GI, and I would say also parents, to think about some of those risk factors for autonomy and wellness in the future, IBD or no IBD. And these are guidelines from the American Academy of Pediatrics, where they talk about a history-taking tool that peds have been using for years called the HEADS, or another one called the CRAFT. But basically, they are screening tools about sexuality, about depression, about substance use, and sort of looking for warning signs. So that young people go off to Cégep, university, their job well. I would say that in pediatric IBD, kids with IBD have some special features related to the disease itself that puts them at a little bit higher risk. And that's because having an intestinal disease affects one's body image, can affect one's growth. Perianal disease especially, or abdominal pain, can affect their sense of confidence and in sexuality. The therapies like corticosteroids, which we really try to avoid in peds GI, have a significant impact on mood and body image, and uncontrolled disease certainly is not a good thing, obviously, for social participation in this age group where it's so important. And in addition, for girls, there are some concerns that they bring up that are related to their contraception and possible risk of relapse or having a blood clot. And for parents, this is really tough because their son or daughter are just going through adolescence, and we all know how challenging that is as an individual and as a parent. And yet they have a diagnosis of IBD on top of that, and it makes it hard sometimes for parents to cope, and that can affect readiness for transition of their kids. So because of that, we really think that kids need, adolescents need the opportunity to be alone at their appointments, and that they need concrete guidance on how to transition towards more autonomy and care for their own health and wellness directly with their healthcare providers, and that they should just need to set goals and for each visit in that trajectory, and a deadline for transfer. And some tools have been developed to help with this. So this is an example of a tool called the IBD-SES-A questionnaire, developed by this is Laurie Kiefer's group in New York. But you can see that the questions are very simple questions that I think anybody could use to kind of figure out, where am I at for an adolescent or a young adult in understanding my disease, and how am I coping? So from the simplest first question, if I understand what IBD is, to a question that's linked to resilience at the end, I'm hopeful that my IBD symptoms will get better. High scores on most of this, except for number 3, which is sort of a yes/no question, are good things for doing well, and low scores are predictors of having a more difficult time. Another complementary tool is a tool that looks at resilience called the CD-RISC. And these are features that any of us can look at to see how we might cope with any kind of hardship or stress. And it's not really necessarily IBD specific, but higher items on these particular categories from 1 to 10 are good, and lower scores are not so ready, not so resilient. So somebody who's really positive, who has a strong sense of self, can handle a bit of hardship, will be able to bounce back, will score high. And someone who is really having a hard time coping with things and really is not at their best is going to score lower. And this score predicted readiness for transfer more than age. And I think that that's something that as a society we need to look at. So because of those, some of those items are not always something that, in my practice, every young person has always wanted to volunteer or feels that they have the space to volunteer. I really think that it's important, and it's been supported by the literature, that there is time alone, and especially if there is a good relationship between either the peds GI or a nurse clinician in a peds GI clinic, that the young person has time for confidential communication, so that if there are issues around resilience, or if there are specific issues related to sexuality or some social struggles that they might be having, that they can be addressed before transfer. And the reality is, at least here in Quebec, that, and I used to be in Toronto, that unfortunately many adolescents with IBD don't have a family physician, or haven't seen their family physician in 6 years, or their pediatrician has no one to transfer them to. So it does come into the subspecialist responsibility to get that ready for transfer. On the positive side, I can say that telemedicine, which has been shown to help access to to adult IBD care, through the PACE telemedicine research sponsored program with Jeff Nguyen, where the silver lining to the pandemic is that we have been using telemedicine for follow-ups for adolescents with IBD. And I can say that for me personally, that it certainly offered a forum to chat confidentially with some of my patients, where in the past, that opportunity was a little bit more awkward and not as smooth. And I think it's actually been a real plus in terms of communication. So going to those factors, when are you ready? Well, the person is ready when they have adequate knowledge about their own health, their own medical history, medications, allergies, when they're sure they have some insurance coverage and they've applied for it, that they can transport themselves to their own appointments, that they can get their own prescriptions, that they feel that they're okay with their treatment personally, not just what their parents prefer, but where the young person themselves says, yes, I'm okay with taking adalimumab or infliximab, or I'm okay taking Modulin for a period of time for a relapse, that it's acceptable to them, and that there isn't any unstable mental health or social issue at the time of transfer, and of course that the IBD hopefully is under control. So what can you do as parents? Well, I think that, parents really need to be well informed, and they are in general, but they can continue to be as informed as their teens so they can support them in their own knowledge journey. And they need, and we've all been through this as parents. I have, university age kids, so I've been there. Is allowing that progressive transition of resumption of responsibility, and it's really, it is key, and respecting that medical confidentiality of their, teen 14 plus to young adult. And it can be hard for parents. So knowing that there are resources and to get some support yourself if need be, if you're having a hard time with this as a parent. And I think parents can really help their kids by helping them navigate some accommodations that they are entitled to at their university, at their CJEP, and help them research for scholarships such as the CCC IBD scholarship that can support them in their education journey. And as parents, kids are busy with everything else. It's really great if you can help them with this. In terms of the medical team, well, we have to make sure that there's a decent referral letter that's complete for the adult GI, and to advise the patient to sign for his or her own copy of their medical record from the archives of whatever institution they're being followed at, either here in Montreal, either at Saint-Justine or at the Montreal Children's. In partnership with the patient, we choose a GI colleague that will be suitable for them consistent with the severity of their IBD, their personal style, their geographical preferences. And as we talked about already, starting transition issues early and assuring control. So those documents that they need are transfer are, their prescriptions, a letter summary from the referring institution, a letter for the CJEP for accommodations or for universities if need be, that the patient and their family themselves ideally have prepared some sort of health binder passport so that they have their own summary that they can take with them, and I'm coming back to that, as well as an emergency plan and contact numbers. So that, as I talked about before, the medical team needs to know about other risk factors, other social, things about around, drugs, alcohol, smoking, etc. before transfer, and trying to address them, and to assess some things about optimism and capacity for self-regulation. I think the simplest question, can they see a positive future, or asking questions about positive plans, is an easy test as to whether they're ready or not for transfer. And sometimes, because the disease isn't well controlled, that they're in the middle of a flare and they're changing medications, that a transfer just isn't appropriate. Or sometimes because other things are going on, that transfer needs to be delayed. And that for me means asking for a dérogation, which is possible to delay and have an extra year to prepare on a case-by-case basis. The healthcare system has its role as well. So in Quebec, we have a network of adult gastroenterologists who are interested in assuming care of young people with IBD who've gone through the pediatric system. We call it TRAC, and it's a list which is geographically relatively well dispersed of people who have signed up to say that they are committed to facilitating this process. The establishing that proof of delivery of transfer by the adult GI to the pediatric GI is something that we're still working on. And so I would say maybe as individuals that it's always nice if you let your peds GI know, or nurse coordinator know that actually that you did see the new adult GI and how it went, because if it's not the right fit, we can retool this. Some people can benefit from patient partners at transfer. We had a master's student, Guillaume Dumais-Lévesque, who did his master's on this subject. but recruitment was a bit difficult to that. So I think so far we think there's a select subgroup of people who might benefit from that. And I would say, use those workshops like today, online support. So after transfer, it's, a whole other gamut of things in adult life. They're beyond the PED scope. So there are ongoing educational opportunities for you as patients and families, and to review unclear topics. And sometimes if the transfer didn't go as smoothly, there's always a possibility of asking for additional information, and I'll come back to that in a second. And for us as pediatric GIs, just going over with the young person before they're transferred, just a little bit what to expect on the adult side that is a bit different. That endoscopy will happen, for example, with IV sedation, but given by a gastroenterologist, not necessarily by an anesthesiologist, that they may be a little bit more aware of the procedure than they were in PEDS, where they were completely unaware. So some additional tools that are really helpful in preparing yourselves for young people to prepare themselves for transition and transfer. I would say if details are missing or if the case is particularly complicated, Zoom has really helped a lot in organizing a pre or post transfer, with permission, of course, to discuss some details about transfer of care. I've done that for selected cases, and it has been, I think, very well received on both sides. For patients themselves, for you yourselves, starting in the mid-teens, I'd really encourage going on the Sick Kids website and filling out, there is an IBD section for their My Health Passport, and I will show you an example in a second. For young people going to school in the US, there is the Doc for Me application through the North American Society of Peds GI, which gives geographic sort of suggestions for new gastroenterologists taking care of young adults, as well as something similar to the Health Passport. CHIO has a transition program that has some interesting features that warrant sometimes your perusal. CCC has launched their My Gut app, which there you can see as a screenshot from it on your left. The Q codes are there, which again helps you assemble some similar information, as well as access to wellness suggestions. It's a very nice tool that will eventually have an interface with a provider, adult GI provider, on a case-by-case basis if it's mutually desired. And I already mentioned TRACK, and in the future, it's underway, but the publication is in development. Crohn's Colitis Canada has supported the PACE transition program led by Natasha Balangala and among others, who have developed transition guidelines for physicians. Hopefully they will be applied more nationally. So this is the Crohn's Colitis website. I really encourage every new patient to go on it, and I encourage towards the end, but it somehow gets forgotten sometimes over the years, so towards the later teen years, I really try and encourage and go back on almost as a new diagnosis to access the latest information, but also some very important information about insurance, which can vary by province, for example. So this is an example of the My Health Passport. It's free. You don't have to be a Sick Kids patient to use it. It has some nice prompts in the questionnaire that eventually ends up with this sort of wallet-sized card printout. Things like whether or not you've had chicken pox before, and some information about vaccinations, allergies, coordinates, phone numbers of physicians, when the last scope was. All of this is relevant, and it pulls it all together in one place. Last but not least is that transition is really a time-intensive process for adolescents and families. It's another skill set added to a whole long list of skill sets they need to acquire. And there's not always as much time as we would like. And sometimes if someone has several illnesses at the same time, the coordination of care can be complicated. And fortunately, in the last, just this year, at Saint-Justine, there was funding provided for a central transition office, and they go under the logo of Parachute to help this process, but also to evaluate where gaps are in the transition process for our patients so that we can do better. So coming back to a model, so this is the UK guidelines for transition of chronic diseases in peds to adult care, to say that there is this disease-specific education and this assessment of readiness and their need for a coordinator and individualization. But I also say sometimes there needs to be flexibility given individual circumstances. And with that, I wanted to thank you very much for your attention today. And I hope that anyone who is adolescent or is about just transitioned to the adult GI system has found it, that it goes relatively smoothly, because our goal is that ils atterrissent en douceur. Okay, so thank you very, very much, and I'm open for questions.
Thank you so much, Dr. Dirks. Hi, nice to meet you virtually. Finally, face-to-face, we've had interaction, so thank you so much. Very well, excellent presentation, excellent information, especially for adolescents and parents who are transitioning from pediatric to adult. I have a whole bunch of questions for you. So I will start with, sorry about that. Is it encouraged for young folks to discuss their journey with IBD with their friends and peers to lessen the alienation?
Yes, it is, as they're older and when they're ready.
Okay.
Yes, it is encouraged to avoid isolation, not necessarily with their whole entourage, obviously, but with a very close, trusted, best friends, cousins, people that their peers who can offer them support and understanding. Absolutely.
And what are the best ways a GI can help build confidence in a young person struggling with IBD, especially if they're shy or introverted?
Well, that's why I would sort of keep coming back to kind of building that relationship and having some time, alone to kind of build a relationship that's not always with the parent present, because, it was true for my kids too, by the way. Both my kids have had health problems, but when you're there as a parent, your kids don't necessarily speak up as much as they would otherwise. And sometimes it's very hard as a parent to resist that urge to respond for them when there's that sort of painful lag. Mm-hmm. But honestly, when the parents are not there, that lag eventually subsides and a conversation starts. So I think that for me anyway, I really I think that the acceptance and the more widespread availability of video interviewing, video appointments is going to make this better and better, because there really is a big difference, talking to, someone in their bedroom or in their living room or their dining room, and that there's not with the entourage and then the entourage leaves.
Right.
It really is interesting how it's better, and there's somehow not that long, anxious anticipation or boring wait for an appointment with other people, and sometimes with age discrepant patients in the same waiting room, and it's not comfortable. If you're 17, if there's a baby on somebody's lap waiting in the waiting room. So I think that this expansion of video care will make it better. And I guess I'm giving this talk because Rena asked me to give this talk about, a human style. And I guess it's about building that relationship, right? so they can talk.
I have another question. I have a few bunch of questions. What if the adolescent is just they're not mature, and they just don't have that, they don't want to become independent and become responsible for their health. So what could we do? Like, if you have somebody who's very emotionally dependent on their parents, is there anything that you would recommend to get them more empowered by to get control?
Well, the first thing is kind of naming it, right? So the first thing is kind of bringing it up. Hopefully bring it up with them directly, not necessarily right away in front of the parents.
Right.
So that's the first thing. And then with their permission, bring it up with the parents. Sometimes it is a dynamic between a parent and a young person that's unique, that sometimes needs some coaching or some family therapy. So we do have, a psychologist who's part of our team. And although we would love if she was, we would love to have 4 psychologists, I think we
right.
could, honestly. We try and select those cases that really do need some help. And sometimes I work in partnership with adolescent medicine for things that were around shyness, around anxiety, around sometimes some sort of trauma that someone has experienced, or sometimes there's alcoholism or other things in the family that are affecting the situation, and have a nice working relationship with adolescent med. And so if someone's very dependent and really not ready and really in denial about, they just got their diagnosis at 17 and a half and they hadn't even had their first menstrual period yet, if we're talking about a young girl, then that's a very legitimate reason for a dérogation and another year to build that confidence.
Mm-hmm. And what's the cutoff age? Is like 20 the maximum, or like 18 is the maximum?
Well, so in Quebec, the usual cutoff is 18. Now, in some places in Europe, it's 16. Mm-hmm. So just to put it in context, and so different societies have different expectations, different, subcultures within our own city have different expectations for maturity and autonomy, right? So the usual is 18, but there are, as I said, there are extenuating circumstances that are valid. So for me, honestly, I try and get on this in advance, and if I see that it's going to be an issue, then I ask for a dérogation before the 18th birthday, and with reasonable justifications, I've never been denied that privilege.
Another question, can a young person who's transitioned to a new GI visit their previous GI to gain support with the transition, especially if they spent years building that relationship with the pediatric GI?
Yeah, so I think the answer to that is yes. There's no problem about outpatient visits, even without a dérogation, okay? I think that, I think it's very important, our roles as pediatric GIs, as pediatricians, as parents, as community members, is to make sure that young people thrive in every way. So from my point of view, there's absolutely no problem having follow-up appointments with the pediatric GI for support or for explanation. It's just that they can't have another endoscopy necessarily without that special dérogation between after age 18. And they couldn't be hospitalized in the pediatric institution without that dérogation, that special privilege by the head of the medical services to say that they can be rehospitalized. But outpatient visits are no problem, and I think they are appropriate in some cases.
And what about, I just lost my total train of thought. I'm so sorry. I'm so sorry. What about, do they get a choice to choose who these doctors?
Yeah. So that's,
they get a choice, and what if they're not comfortable with them? Are they allowed to move to another?
Yeah. So there's, so I we're lucky that I think that it's not written in stone who the new physician is. So that's why I talked about there being a partnership and a discussion, and that there's this network of adult gastroenterologists who expressed a specific interest in IBD and taking care of young people with IBD. So, for me, there's a discussion that starts somewhere around age 17 about who the new person will eventually be. And so we discussed things like, if they want a same-sex gastroenterologist, like a woman if it's a woman, and a man if it's a man, or does it not matter? We talk about, geographic location, where they're planning to go to CJEP or to university, if they're moving out of province, making arrangements for a referral to an appropriate adult gastroenterologist, IBDologist in another province. We talk about more community hospital versus university health center kind of model. Sometimes if someone's been very sick and it's been very complicated care, I will, steer them towards, if they're staying in Montreal, towards, the MUHC or the CHUM, because of the kind of the availability of, a surgical team, special interventional radiologists, and more gastroenterologists, more specific IBD, maybe nursing supports that they might have. So there's a few situations where I'll say to someone, I really don't think it's a great idea that you be followed in a smaller institution because all of this happened. Mm-hmm. And then we pick what we think will be the most appropriate for them. And with telemedicine and telehealth, I think it will be even less difficult than it used to be. But absolutely, it's a two-way street, and I usually discuss options and names in advance, and then I say, go read about them, think about it, get back to me.
That's great. Gives them an opportunity to choose, and that's great. Another question, what's the general timeline in Quebec for a young person to find a GI, or for someone like a pediatric GI to help them find a GI? Because it's generally less support for adult IBD care in Quebec.
Yeah. So again, I'm actually surprised how fast it is these days. Because it's not for the patient to find the adult GI. It's for me or the other pediatric GI to help them find a colleague who we know will be receptive, and to get everything done in a timely manner in advance so they have what's needed. And once in a while it goes faster than I planned. Like I referred one of my patients at 17 and a quarter, because I thought it would take a while, and I'd made a treatment change thinking he'd be seen in the spring, and the mom emailed me in a panic saying, they're asking to see him next week. As if I was abandoning him, and it wasn't, So I could see how somebody, if you develop a relationship, and they become very attached. But it goes both ways. It's, and we're all kind of, not all of us, but we're all pretty attached to our patients in PEDS. It's the nature of the specialty, right?
Yeah, you sound very devoted. Another question is, do many GIs ensure to address parents so that they do provide an opportunity for their minor that kind of have one-on-one time with their GI to address sensitive issues, like even in their teens? To speak to you, do you find parents give that opportunity, or they don't want to always give that opportunity to their minor to have one-on-one time?
I think that just sometimes we don't ask enough. I make a point of asking, and honestly, I can't remember the last time a parent refused, to be honest. But I think that when someone has a busy clinic, they maybe don't give that opportunity for the teen to be alone with their PEDS GI. But I think most parents, when I bring it up, and there's a way of presenting it, are really quite understanding, and in a way, I've often find quite relieved that, that maybe, you are going to ask questions that they can't always, that they can maybe ask, but that they won't necessarily get an answer to.
But then I know that they can't get the answers from you afterwards.
No, and they know that there's not, that there is, as of age 14 in this province, young people are entitled to confidentiality of care, unless they're going to harm themselves or they're going to harm someone else. That's the only situation where one can break confidentiality.
Okay. I'm just looking here, and if anybody else has any questions or anything else. So I don't see any other questions on my side. I just had a question, just a side note. Like if a child, there's obviously different tons of different circumstances and people who have tons of different diseases. But let's say you have somebody who has like mental disabilities, and what would happen in that circumstance? They don't have the maturity to move and transition. Like they can't fully take care of their own health.
Yeah. So again, I guess there's two possible scenarios in that. And I've seen both, actually, obviously. So one scenario is that someone has a developmental disorder that has been present since early childhood. That is chronic and static or degenerative, and so it means that it gets worse over time. And in addition to that, they have IBD. So that person will already be followed by usually a developmental pediatrician, or who might or may not be part of CRN, and a neurologist, and maybe a family doctor, So those cases, usually it's a planned transfer of care with both ped services talking to each other as to where, and usually then the actually developmental disorder can sometimes take a little bit of priority on the IBD in terms of where they get transferred to. Sometimes there are other, sometimes there are gastrostomies involved, sometimes there's epilepsy medication involved, sometimes there's, all sorts of other physiotherapy, occupational therapy, sometimes there's a lot of other things involved. So then it will be finding an adult gastroenterologist to care for that person, ideally in the same medical center. That's sort of one scenario. And that usually happens still around age 18. And then there's another scenario that can happen where someone has an underlying mental health problem that has just presented with psychosis or severe depression or disabling generalized anxiety, or has very significant learning disability, and they've immigrated to Canada and they have never had appropriate assessment and care, right? And in that case, there is again a necessity to ask for that dérogation and to give them access to those things that are often taken care of in the pediatric sphere, and then transferring a year or so later when things are better defined and there's a better treatment plan.
Well, we have a few of your past parents of patients who are on today, who are thanking you and who you helped greatly in the past. So I could see how devoted and committed you are to helping people, and they're all very grateful, and they're all thankful, and they're all said that you were so kind and helpful. So I could see that, and I thank you for your generosity of time, for putting the presentation together, again, for doing the podcast this week and helping to promote the event. For all this great information that you shared today. I know it was wonderful. It was amazing, and I want to thank you just for your time and just supporting Jaclyn Fisher Education Symposium, and I know you were her doctor, so I know that was a special relationship as well.
Anyway, it's really my pleasure. I thank all the attendees for taking part of their Sunday. It's even, it's not snowing, it's not raining.
Not snowing, not raining. It was a nice day.
So honestly, you know, I thank you for taking the time, and
Well,
it was fun. Thank you.
well, it's been an honor. Thank you so much. Been an honor meeting you. It's been an honor getting all that great information from you. So thank you so much.
So, you know, I did put some references at the end.
Have a
So
good rest.
yeah, so
Yeah,
if
sure.
you actually want
Sure.
to, and
Go ahead.
I know you're going to be sharing the slide set, so they are,
If they want, yeah.
but they are, you know, they are pretty reader friendly, I would say.
Right. And then there was your contact information, I believe.
Yeah, that's just my email, as we talked about before, Cindy.
Yeah.
It's publicly available. Anyway, that's my Saint Justine email.
Yeah, and you work at the, again, she works at the Saint Justine, the gastroenterology department. And you have your references. Again, we thank BG Communications for translating all of our PowerPoint presentations so that our Francophone participants can understand what was going on. So thank you so much. I want to respect everybody's time. I just want to say a few words, and then I'm going to pass it on to Jackie's sister, Rachel Fisher. So
great.
Thank you so much again. Have a wonderful rest of your day.
Yeah, you too.
Bye-bye.
Thank you, everyone. Bye-bye.
Thank you. Pleasure. Hello, everybody. I'm back, Cindy, and I just want to say a few ending words before I sorry about this. Sorry about this, everybody. I'm trying to get to share my screen. Okay, so I'm just going to share my screen with everybody, and we will get back to being started again, just for an official ending. So thank you. I wanted to thank all the participants for attending today. I wanted to thank Larry and Rena Fisher for supporting, and Rachel Fisher for supporting Jaclyn Fisher Education Symposium, and for your generosity and for your help with everything. I want to thank my own colleagues for helping me and supporting me and collaborating. Couldn't have done that, this whole organization, without them. And I want to especially thank all the amazing presenters who were absolutely amazing and a pleasure to work with and provided, I think, amazing information. So I want to thank Dr. Friedman, Dr. Dirks, Dr. Zwingerman, Natasha Haskey, and Dr. Tripp, and Lynn Watchman for her yoga session. So I just want to say a huge thank you from everybody at Crohn's and Colitis Canada. And if you'd like to follow us, we're at Get Gutsy Canada on Instagram. You could also follow us at Facebook and Twitter, and also crohnsandcolitis.ca for a lot of other great resources that will help you. And we hope you enjoyed the presentation. We thank you for being part of it. And without further ado, I'm going to introduce you to closing remarks for Rachel Fisher, Jackie's sister, Dr. Rachel Fisher.
Not sure if you can.
Yeah, we see you. Go ahead.
So on behalf of myself, my parents, and the Jaclyn Fisher Foundation, just wanted to echo those thanks to all of the amazing contributors and presenters who took their time and shared of their expertise to make this really an excellent symposium. Thank you to Cindy and Mariana and the staff of the regional office for helping to organize and publicize this day. We are really grateful that this has come together so well, and we want to thank most of all of the participants for helping us to continue to realize Jackie's dream of empowering through education so that everyone with IBD can live healthy, full lives. And we invite all of you to visit the website you see at jackie.org to find out more about Jackie and our mission and what the foundation is doing, and to please give us feedback and ideas for next year, because this is going to be an annual event. And we encourage you to share the fact that the information shared today has been recorded and is going to be available for people who may not have been able to join us today specifically. Merci à tout le monde, à tous les contributeurs et le membres de l'Office régional, ainsi que tous les participants, et à BG Communication pour la traduction pour la communauté francophone. Merci de nous aider à poursuivre dans la vision de Jackie, et à vous revoir à la Symposium de l'année prochaine. Looking forward to seeing you again at next year's Symposium.
Okay, thank you so much, Dr. Fisher, for those final words. And I think as of now, I'm gonna end the meeting. So like she said, we're gonna eventually be able to have it, we have it recorded, and we'll have it somewhere either on our website, on our YouTube channel. I'll be able to let you know. Also, if you would like any of the presentations, I could send them via PDF. And if you want any of the contact information, you didn't get it down, I could send you that information as well. So I hope you all have had a great day of learning, and wishing you all a great rest of your Sunday. So thank you again for attending. Have a good day, everybody. Bye-bye.